Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to you all. My name is Azrul Maukalib, the head of the Galen Centre for Health and Social Policy. Welcome to this morning's roundtable discussion focusing on strengthening cancer care amidst the COVID-19 crisis. We're fortunate to have the support of the Malaysian Cancer Care Coalition Taskforce, or the M3C, of the Pharmaceutical Association of Malaysia for this meeting. The agenda for this morning can be found circulated to you through the chat box, which you can find there in your Zoom platform. If you do not have a copy, my colleagues will be circulating a copy of it to you shortly. Please do refer to the agenda for this morning's events, for which there will be a few sessions, and I do hope that you'll be able to stay on for the whole session. And we do hope that also you'll be able to participate in the debate, but also in terms of the Q&A that will be put forward during the sessions later by the different speakers. So, ladies and gentlemen, these are abnormal times with so many challenges facing us. It may seem that everything is about COVID-19, but the reality is that there are many other health crises which have predated this one and will likely continue beyond this present one. The one I am referring to is, of course, the crisis of non-communicable diseases, of which cancer is one of them. Before I go into the meat of my speech, I just wanted to note that today is actually World Ovarian Cancer Day. So I would like to just wish everyone, well, not so much happy, but definitely let's work towards addressing the issue of world ovarian cancer and strengthen our commitment to it. So it has been a long couple of months since the imposition of the first movement control order in March 2020, which became the conditional MCO, and then the RMCO, recovery MCO, and then the second movement control order, and then the CMCO, and now we are seeing a targeted MCO across different parts of the country. If it seems long to us, it has even been longer for our colleagues at the Ministry of Health and the public healthcare system, who have been at the forefront and on their feet responding to the COVID-19 epidemic back in late December 2019, before it was even named COVID-19. I'm sure that all of us here would like to continue to convey our thanks, appreciation, and gratitude to all of our colleagues there in the healthcare system who are working tirelessly, working to help manage and mitigate this epidemic. We are just beginning to see the indirect effects of the COVID-19 crisis on cancer care during the MCOs, and certainly with the one that is now being put into place. Many patients faced troubles with referrals and rescheduling of their treatments and surgeries. Last year, there was the launch of the Malaysian National Cancer Registry Report 2012-2016. And unfortunately, just like the National Health Mobility Survey, it was sort of submerged due to the intense attention and priority that was placed on COVID-19. And certainly many of the findings in these reports were less visible compared to the kind of attention that we would actually see normally for the findings of these reports. I won't share the findings with you at this point, but definitely some of my colleagues will as an update to our discussions today. But one thing is very clear, that presentation of cancer cases remain late. Majority of cancer cases are still coming in, more than 70% at stage 3 and 4. The number of treatment options that are available for those who are in the late stage remain limited and specialized to certain categories. There is an uptick, it seems, from those earlier cases of there being more cases being detected, which allows for people to seek treatment primarily now in the public healthcare space, but still it is very clear from what we can see from the data that more cancer cases is likely to be seen. The incidence will likely increase in the next years to come. And this was all before the pre-COVID-19 crisis. And certainly one of the predictions that have been put forward is that we're likely to see a deterioration in the kind of cases that we're seeing today, where even there is a possibility of deterioration in stages for those who have been diagnosed as stage 2, possibly going to stage 3 and so forth, due to the inability to access treatment that's available to them. So it is all going back to the issue of survival of people living with cancer. And certainly we want to be able to see whatever we do is in the best interest for the people living with cancer. And this is something that has driven our agenda at the Galen Centre for Health and Social Policy. And certainly when we are talking about groups such as the Cancer Care Working Group, the ATTAC, for example, who are all working together, the different groups working together, trying to improve the issues, the concerns, and the situation of cancer in Malaysia. So I believe, as all of you here today, that the situation that we see today doesn't have to be this way. We can do better. We can make a difference, and we definitely can improve the survivability and the lives of those affected. For all these reasons, the Galen Centre has convened this roundtable discussion to discuss the state of cancer care in Malaysia amidst this COVID-19 crisis, and how we can harness the energy and people in this room, and how we can, most importantly, build on the partnerships and coalitions and collaborations that we already have today to move forwards, so that we can increase the quality of life for people living with cancer, but most importantly, to be able to address and respond looking beyond the COVID crisis as it is. We have gathered so many interesting people in this room today for this discussion. I do hope you'll take advantage of their presence to have a discussion, ask your questions, and see how we can work together to move on forward. And to start off this morning's discussion on this point, I can think of no better person to help shine some light and inspire us a bit. And that is shall I say newly appointed, or has it been enough time ready to say that he has already been appointed for a few months now as the chairperson of the Parliamentary Select Committee for Health, Science and Innovation, YB Kelvin Yee, who is going to be speaking to us and to help us start off this morning's discussion, and to help us set the tone for where we want to be regarding this issue. So with that, I hand it over to you, YB, Dr. Kelvin Yee. Go ahead, sir.
Thank you so much, Azrul, for the really amazing introduction. I'm really honored to be invited here to share some of my thoughts, as well as to learn from each and every one of you. So first and foremost, of course, good morning, salam sejahtera to each and every one of you, ladies and gentlemen, distinguished panelists, colleagues, and many of you that I have a privilege of calling friends. So I think the people in this forum represents both the government and private sectors across a really broad spectrum of disciplines, including not only health, but also social and behavioral sciences, insurance, private hospitals, pharmaceutical industries, patient support networks, and of course, caregivers. So you see, we have one thing in common which brings us all together today, and that is our concern and commitment to tackling the growing burden of cancer in our country. So it's been, I think, at least more than a year since COVID-19 outbreak began in Malaysia. COVID-19 has caused an unprecedented societal turmoil, triggering a rapid and still ongoing transformation of healthcare provisions on a global level, including challenges this pandemic poses on the care of particular vulnerable cancer patients, and of course, subsequent psychosocial impact on them. I think last year, I think Azrul has mentioned, we hear news, especially during the first MCO, where many cancer patients face difficulties even for their follow-ups. Some were held at roadblocks on the ways to follow-ups. Many had to defer their treatment due to fear or even concerns of going to hospitals. And even after 1 full year right now, some areas we are still in an MCO. While many people are worried about the different COVID-19 variants, I am actually very worried about the different variants of MCO that we have right now in our country. But with that said, I think this COVID-19 is an unparalleled health crisis. Number one, of course, which no healthcare system is fully prepared, and has caused a tremendous strain in our healthcare system, as well as reveal gaps which we must look at seriously due to years of neglect before, and how we should move forward and improve them. And of course, number two, it affects directly and indirectly the cause and treatment of many common illnesses. And number three, of course, oncology patients are particularly affected, since they are a highly vulnerable group in the current pandemic due to their many immunocompromised status caused by both the cancer and also various anti-cancer treatments. So I truly believe that oncology patients deserve particular attention during this pandemic due to those reasons, and of course severe outcomes of COVID-19 infection due to the underlying malignancy and of course the anti-cancer treatments as mentioned. So in this new landscape, I think the cancer community is steering a difficult course amid several challenges. I think revisiting optimal standards of cancer care, facing persistent evolving shortages, and acknowledgement of the paradoxical need to keep patients away from healthcare facilities. And that's why there's this ongoing challenge of balancing the risks of admission into a hospital with the possible risk of a SARS-CoV-2 infection, which has also an emotional impact, not only on patients, but also the medical staff. But with that said, even so, before even COVID-19 arrived, we were sounding the alarm that government authorities were not paying enough attention to primary care and of course preventive care, particularly cancer, where late diagnosis is sadly to say the norm in order to avoid later complications. Today, I think studies have shown that pap smears have gone down 32%. And when it comes to prostate cancer, 60% of the people present late at stages 3 and 4. And breast cancer and colorectal cancer face similar situations of late diagnosis. So there is gaps in timely diagnosis and care, which existed before, not still exist, but also have widened in terms of access to timely diagnosis, treatment, and care. It's a fact that treatment gap exists not only between private and public healthcare, but of course between the Ministry of Health and also Ministry of Education facilities, as well as the gap between urban and rural communities. So this continues to be a very complex, multifaceted challenge due to the increasing burden and the responsibility of cancer care. I think with costs of healthcare in the private space becoming extremely higher, we see many cancer patients are forced to move to government hospitals when their insurance run out or their savings are exhausted. So even before this COVID-19 crisis, almost 2/3 of cancer patients access public hospitals for cancer treatment and care. Likelihood this is not likely to change. It may increase due to the economic challenges that people are facing due to this COVID-19. So this will actually means that the pressure on the public healthcare will increase significantly, and we need to be prepared for that. So besides needing more and retaining our existing oncologists, we need more allied health personnel such as specialist nurses, radiographers, and so on and so forth. So the gaps in skilled manpower, particularly in the public sector, cannot be emphasized enough, and it has to be looked upon and addressed. So, but despite these limitations, I think right now we have 9 oncology centers under the government, 7 in Peninsular Malaysia, only 2 in East Malaysia. So currently there is a previously announced Northern Oncology Center is currently under development, which will soon provide radiotherapy, cytotoxic treatment to that parts of the region. I'm from Sarawak. Sadly to say, we only have one center catering for a land size the size of Semenanjung, Malaysia. So we consistently emphasize to the public that being screened, diagnosed, and treated earlier will actually increase their likelihood of being successfully treated, something that we need to push forth and push forward the message of that. However, I think more than 50% of patients continue to present themselves in later stages. We need to ask why, address this behavioral, and also double our efforts to get people diagnosed earlier and link them to appropriate treatment. So linking people from diagnosis to treatment has been identified as a huge issue of concern. Patients, whatever their backgrounds, are still resorting to sometimes traditional or supposed alternative treatments upon learning their diagnosis rather than immediately going for allopathic medicine. Look, some of this are understandable. When people receive a diagnosis such as cancer, sometimes they are concerned and they want to explore different avenues. But it's important for us to educate them, to comfort them, to support them, to show them that what decisions based on science and data, what is best for them and what is best for their prognosis. So due to that, this has resulted in, of course, significant treatment delays, and in some cases allow the disease to progress to later stages where, of course, options are few, prognosis are not as favorable. So that's where the questions we need to ask: how can we educate and inform patients better to increase their literacy and have better decision making? But when they do come later, it does not mean that we ostracize them, we cut them out, we don't have anything to offer them. But there are many new cancer therapies that are being available right now. They are novel, innovative, effective, and often spares patient the need to undergo chemo, which is often regarded as highly toxic, and of course, to certain people, very scary outcome. So for decades, I think most of the more effective medicines have been fully subsidized by the government. I think this is to ensure, of course, better possible health outcomes. Novel treatments which do not meet the above mentioned criteria are still accessible to patients through innovative financing models, patient access schemes, and even industry-sponsored clinical trials. But whatever decision that is made should be in the best interest of the patients and the provision of quality care that no one is left behind. So we have seen public-private partnerships come to the forefront to help address the treatment gap problem. It has been the go-to approach to solve access problem. But we need to bring together health and non-health sectors to develop innovative, localized solutions for cancer care to tackle the growing burden of cancers. I think ultimately the best health outcome we can hope for are improvements in survivorship, where patients are able to be treated, get back to their feet, be able to have a functional and be a productive member of society, and be, of course, with their loved ones. I think looking at cancer data currently available, we definitely need to do more work in this area. Of course, it is sobering to note that breast cancer, as an example, Malaysia has one of the lowest survival rates in the Asia-Pacific region, with a 5-year survival rate of only 49% compared to 92% in South Korea, 83% in Singapore, and over 60% in China, and of course 52% in India. So how can we integrate survivorship into existing cancer policies and strategy and make that a focus of our work? Though it is not currently included within the current national strategy, I think survivorship is nevertheless a major overarching objective for any cancer control plan. So the fact is that we do not know enough about survivorship to respond properly. Therefore, we need patients, dear families, and caregivers to voice out and help share their thoughts with us to see how we can do better in this area. We can respond adequately to the threat of cancer on our own. The government, the private sector, patients groups, politicians, policymakers, all of us need to work together in partnership for this important issue. So I think ownership of cancer issue must go beyond health, but also into sectors such as labor, finance, urban planning, and of course, education. So we need this combined movement and energies of non-government organizations, the academia, private sector, healthcare stakeholders, caregivers, and patients. And I'm looking forward to hear from each and every one of you and to learn from each and every of you. With that, thank you so much. God bless you all, and back to you, Azrul.
Thank you, YB Dr. Kelvin Yee. That was quite inspirational and definitely a call for action for us to take heed of. And speaking as the chair of the Parliamentary Select Committee on Health, Science and Innovation. The next person that we have to speak to us about setting the tone for this morning's discussion is quite a distinguished and well-known individual who is honestly not alien to the very themes that was mentioned just now by Dr. Kelvin Yee. We have with us Dr. Rosuzana, who is a clinical oncologist and the current head of radiotherapy and oncology department of the Hospital Kuala Lumpur. At the national level, she is the head of service for radiotherapy and oncology at the Ministry of Health, Malaysia. She has been a relentless voice for patients and clinicians in being able to choose hope over despair when facing cancer. COVID-19 has dealt a hard blow during this period to the radiotherapy and oncology services nationwide. And she will be speaking to us about what we can learn from the COVID-19 response to improve cancer care. With that, I hand it over to Dr. Rosuzana.
Assalamualaikum warahmatullahi wabarakatuh and a very good morning. First of all, I would like to convey sincere apologies from Datuk Dr. Nur Hizan and Dr. Ahmad Razid that was invited previously for not being able to come today. And this text that I'm going to read is actually prepared for Datuk Dr. Nur Hizan. So please allow me to share, because of the several points that were also given by me to him, for this text. So first and foremost, I would like to congratulate the Galen Centre of Health and Social Policy for organizing this roundtable discussion on strengthening cancer care amidst the COVID-19 crisis, and to the work and progress in strengthening cancer care in Malaysia. As the healthcare sector continues to grow and become more complex, this discussion is very timely as it is relevant to the current health landscape we are experiencing, and I am pleased to be with all of you here today. In our battle against the pandemic, not only did we have to quickly adopt and adapt to the new norms, but we also had to tap into our creative sides to rethink and redesign the healthcare service delivered to transform and cater the requirements of the pandemic and post-pandemic period. As part of the strategy in combating the virus, the Malaysian government has taken the approach of infection containment. Quarantine centers were established utilizing the existing training institutes, dormitories, and even hotels. The readiness of hospitals to deal with COVID-19 was assessed and categorized into COVID-19 and non-COVID-19 hospitals. As of 30th March 2021, a total of 63 hospitals have been categorized as COVID-19 hospitals, including 2 university hospitals, of which 7 are currently running as full COVID-19 hospitals, while the rest are operating as hybrid hospitals. All oncology centers, IKN, HKL, Hospital Pulau Pinang, Hospital Sultan Ismail JB, Hospital Wanita and Kanak-Kanak Likas, and also Hospital Umum Sarawak Kuching are now operating at full capacity. The hospitals I've mentioned before, except for IKN, are hybrid hospitals, and they are subjected to staff redeployment, including doctors, nurses, and medical assistants, and also service shrinkage when the burden of COVID-19 infection increases. During the first 2 weeks of MCO last year, we witnessed the interruption of services where the number of patients to oncology clinic, chemotherapy daycare, radiotherapy treatment, and ward admission reduced by almost 50%. As MCO continued, the service gradually increased, and at the 4th week service, were operating at 80 to 90% of pre-MCO. After a year, we have learned more on the natural history of the disease, and phase 2 vaccination is currently being rolled out, focusing on elderly individuals with comorbidities, including cancer. Despite current progress, the number of patients at any one time needs to be limited. We also need to practice social distancing continuously and to prevent overcrowding in clinic, wards, and treatment areas. So cancer has been a priority throughout the pandemic, which is why hospital staff have fast-tracked patient access to more convenient and kinder treatments to provide as many people as possible with safe and effective care to ensure the cancer diagnosis, treatment, and palliative care can continue safely. In 2019, the number of outpatient visits to the oncology centers has increased to over 134,000 as compared to 107,000 in 2015. Inpatient admissions have also increased over the years, with 25,400 in 2015 and more than 32,600 in 2019. So in the year 2020, amidst of the pandemic, MOH oncology centers reported 14,396 new cases, 113,861 follow-up cases, and more than 75,000 patients underwent radiotherapy, brachytherapy, and chemotherapy. So these are some measures taken by MOH hospitals in response to the pandemic. So as we know, the number of patients attending MOH hospitals is really high, which leads to overcrowding. Healthcare teams are taking care to reduce any risk to make it as safe as possible. They are following strict infection control measures to keep patients and themselves safe. Careful scheduling and staggered timing for clinic appointment and radiotherapy treatment, and ensure that patients actually adhere to timing. Patients who are independent and fit are discouraged to bring company to clinic, wards, and treatment areas to lower the risk of spreading the infection. The benefits of treatment versus the complication from the treatment and COVID-19 infection need to be weighed carefully. Patients who are on palliative chemotherapy will be discussed on treatment postponement or delayed. We also consider shorter radiation fractions for selected patients for certain cancers like breast and rectum cancers, according to recent published evidence during this COVID-19 pandemic. Elective surgeries are being postponed when COVID-19 cases escalate, but oncological surgeries are given priorities. MOH also recognizes the importance in having strategic collaboration with the private sector through various mechanisms of public-private partnership, not only to reduce the cost of doing business, but also to ensure a continuous high quality of care to the Malaysian population. Such an example would be the engagement of MOH with private sector in dealing with the COVID-19 pandemic by outsourcing of treatments such as radiotherapy for cancer patients. Hospital Kuala Lumpur has started virtual clinic on selected patients who are on follow-up or on hormonal treatment, provided they are agreeable and given their consent. The guidelines for virtual clinic was produced by MOH July last year. Apart from the consent, the patient must have the adequate tools and infrastructure which enables them to do video conferencing. Apart from virtual clinic, we are also having the multidisciplinary team meetings online, the MDT meetings, not only attended by oncologists, but also various teams like medical, surgery, pathology, and radiology. Hospital Umum Sarawak has intensified their teleconferencing service with district hospitals in Sarawak, like Hospital Bintulu and Hospital Miri, before they are used to do visiting clinics to both hospitals. They give advice to medical officers and specialists regarding chemotherapy administration. So ladies and gentlemen, the exceptional circumstances of COVID-19 pandemic have accelerated changes in the healthcare delivery landscape. All hospitals must be ready to continue their daily operations according to the new norms. This is to avoid and control the spread of COVID-19 and to ensure that the hospital is a safe place. Hospitals should always be prepared to deal with any potential increase in COVID-19 cases while ensuring that the management and the treatment of non-COVID-19 patients, especially cancer, is given priority. Thank you.
Thank you, Dr. Rosuzana, for your kind thoughts and certainly for sharing your insights concerning what we are able to learn from the COVID-19 response to improve cancer care. And I think the emphasis in that speech on the need to maintain the quality of care and treatment for those needing the kind of support and care that we have come to expect, even amidst a COVID-19 crisis, is definitely something that very often, I think many of us perhaps even took for granted before the crisis. And now that the government is maintaining that commitment to the kind of level of care, even though the current health system is being stressed with the kind of demands that are being put into place for epidemiological control, we really appreciate the work that our colleagues there in the public health and now the private health sector are doing to actually ensure that Malaysians are able to be kept safe and to be also having the same kind of access to the level of care that they have come to expect from the healthcare system. So thank you very much again to Dr. Rosuzana there for her remarks and comments. For the next session, we have with us, and this is expanding upon the points that have been raised by our two previous speakers, YB Dr. Kelvin Yee as well as Dr. Rosuzana. We have with us two distinguished speakers who will be speaking on the issue of looking at building better and strengthening cancer care policies. And to guide this discussion, to also introduce these two speakers, although honestly speaking, both of them are quite well known in the cancer space, probably don't need that much introduction, but I'm going to do it anyway. So I would like to introduce our chair for the session, which is Professor Dr. Nur Aisha Mahtaib, who is a consultant breast surgeon and the director of University of Malaya's Cancer Research Institute. University of Malaya, in conjunction with the National Cancer Society of Malaysia, has spearheaded the successful application of the Greater Petaling admission to join the City Cancer Challenge project in 2019, which is still currently ongoing, which aims to streamline public and private health systems to drive better patient outcomes. So she's one of the leading figures in the cancer space and definitely someone for us to continue to look out for in leading the march towards better and improved cancer care policies. So without further ado, I hand it to Professor Aisha to now take over the floor. Go ahead, Prof.
Thank you, Azrul. I think as what you mentioned, I think the biggest concern and the biggest focus is how people can work together. I think that's the biggest message for all of us today. So, so first of all, before I start, we are going to go on to a panel discussion on how to build better and strengthening cancer policies in Malaysia. So without further ado, I think we have two very well-known panelists. Dr. Faizul Izwan Mustafa as well as Dr. Murali. So let me introduce them. So Dr. Faizul is the Deputy Director of the Disease Control Division, Ministry of Health of Malaysia, where he is responsible for the policy and program development, as well as the strategic implementation in NCD prevention and control. He has led the development of several national strategic plans, including the Malaysia's National Cancer Control Plan, and is actively involved in global public health platforms. As a leader, Dr. Faisal combines high-level experiences in the government with engagement with civil society and multilateral institutions. So welcome, Dr. Faisal. So we are happy to have you, and we hope to hear more inspiring, the future directions of how Ministry of Health has this role as a leader in improving care for cancer patients. And next, I'd like to introduce Dr. Murali. Dr. Murali, are you there?
Yeah, yes, I am, Prof.
Okay, sorry, I didn't see you there. Okay,
sorry.
Murali, okay. Dr. Murali is one of the most, I think, hardworking person I know. He holds, I think, webinars like almost every week. He's a public health physician and a general manager, and now as the medical director of the National Cancer Society Malaysia. So he's wearing two major hats in National Cancer Society, where he has served since 2018. He was trained in Chulalongkorn University and London School of Hygiene and Tropical Medicine, and is actively engaged in health system reforms for cancer. And not many people know, but Murali can actually speak Russian. Okay, so that's what I found out about Murali, which is very interesting.
Okay.
So without further ado, so shall we address the issues of the cancer policies that is in existence in Malaysia? And maybe how did the COVID-19 pandemic affect the implementation of these policies? So maybe I'd like to invite Dr. Faisal, maybe you can give us a little bit of an overview of what sort of policies are there in Malaysia that affect cancer care, and how it has been affected by the pandemic.
All right, thank you very much for the kind introduction. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Firstly, thank you very much to Galen for inviting me again. We had this cancer conversation several months back, and Azrul was supposed to get back to us for part 2, right, Asha? But he never did.
He never did.
Yeah, he never did. So bad lah. So I'm gonna rat him out in public right now. And Murali, it's a pleasure again to have this conversation. So one of the key themes that is being discussed globally is what we call the Build Back Better. That is looking at COVID-19 right now, and even at this point of the pandemic, start thinking what lessons we have learned. Otherwise, it is for naught. We're going to experience further pandemic later on, and it is very important to learn what the lessons are. And for me, how the government, how the institution, how the public is responding to COVID-19 itself is an eye-opener, to say the least. That we can pull from COVID-19 to NCD in general, and cancer specifically as well. So why do I say this? Firstly, we look at COVID-19 as a pandemic, and we have always described NCD as a silent epidemic. So opposite means COVID-19 is a very loud epidemic, and we have another silent epidemic. The other similarities is that the policies that is being developed for us to manage COVID-19 has the political dimension to it, has the economic dimension to it, has the social dimension to it. So this is to build upon what YB Calvin said earlier, addressing the, I'm paraphrasing, but he did say sectors outside of health have an important role to play. Very much for cancer, sectors outside of health have a very important role to play. The other thing about COVID-19 is it amplifies the disparity. It amplifies the socio-economic disparity of the population. And one last point I'd like to raise about COVID-19 in terms of what it has highlighted, it is very important for us to look at public perception of the issue. This is very important again in policy making. All right, so going back to the earlier question by Asha about what are the policies. So when we talk about cancer care, it's a point I like to make is that don't just think about the treatment. We talk about cancer prevention and control, the whole continuum from the health education and prevention, from early detection, which includes some screening. Then you have your management, and management is what people most often talk about. And then you have your rehab, and then you have your palliative care, right? So that's the whole continuum. The other aspect about cancer is that the social and economic aspect as well. So it's not just a health issue, it is also a social and economic issue. The other thing which people not often talk about is that as we become more developed, we expect incidence to go up. And in developed countries, cancer in terms of burden of disease have already overtaken cardiovascular disease. And I think for Malaysia, we are on that trajectory. You can see that already. And as our management becomes better, we have more survivors, all right? So cancer survivors are also faced with different challenges, not just from the health domain, but also from the social, from the work domain. So you have people who are surviving cancer. And of course, if they live old enough, you have what we call the other comorbidity. So you will have heart attacks and stroke. So they becomes a bit more complex to manage. All right, so that's in general broad strokes. For me, when I think about cancer, I hope people don't just look at it from a very small viewpoint. It is, you have the whole continuum, and you have all these different domains taking place.
Okay, so going back to what, sorry, I have to switch off my video because sometimes my bandwidth is a bit challenged. So you were saying about the whole trajectory. So in terms of policies, in terms of plans or strategic plans, we know that there was a national strategic plan for cancer control some time ago. And maybe I would like to also hear from Dr. Murali what you felt, what you think about the NCCP, because it's ended already. So we are now in 2021. So that was 2016, 2020. How do you think the pandemic may actually change the way we write this type of strategic plans?
Good morning, Prof. Good morning, Dr. Faisal. And of course, very good morning, ladies and gentlemen. Thank you so much for the invite. Always a pleasure to be able to speak to such a distinguished forum. I think, Prof, Dr. Faisal hit the nail on the head. And I think one of the issues with NCCP, and this is it's really going to be a ball around the park from what usually CSOs talk about. The NCCP is very focused on delivery in terms of the government sector, and which is rightly so. But I think Dr. Faisal has highlighted today very importantly, and we can see this in COVID, that cancer actually, the clinical aspect of cancer management is just one aspect. There's all these other aspects, the social aspect, the political aspect, the economic aspect, which is much more wider than it can ever be encompassed into this one single document of the NCCP. So if there's anything that seems to be like a big shortcoming with the NCCP, it's the fact that we have not had the capacity, and I think we have changed as well. In the future NCCP, we might start looking at all these other kind of components or that make up actually cancer care. And one I actually would like to borrow on Dr. Faisal's other kind of approach when he looked at other NCDs. There has been some effort in those strategies that he and his team in the government have drafted to look at like a wider whole of government approach. So it really crosses health. I mean, sharing with you all during the first kind of impact during COVID, in the first few weeks, I think the concern for most of our cancer patients, besides like not getting appointments, getting difficulties to travel and all that, was actually a very basic issue of food. Many of them didn't know where their next meal was going to come from. So we actually had to spend quite a lot of time, energy, efforts working on the ground to put something simple as food on their table. Is this part, or is this part of the NCCP. No, it isn't at this point in time. And very often, as Dr. Faisal was saying, we're bothered with the clinical management of the disease, but there's so many other pockets of it that lie unaddressed. And this actually, Prof, in my opinion, needs a whole of government, whole of society approach, rather than us keeping on banging on MOH saying, oh, you know, or government for that. I would still limit to MOH because I think government as a whole can do much better. But rather than we falling back on the clinicians and saying, you know, you need to treat more radiotherapy, you need to give more inpatient beds, there'll never be enough. You know, they will never be enough. Could they be improved? For sure. That is a case to make for that as well. But could we increase the numbers? Do we need centers in places like Sarawak? For sure. But it will never be that these numbers will ever be enough. So, you know, we need all these other kind of policies that need to come into place to manage the situation. And as Dr. Faisal put it very appropriately, you can, if there's ever been a laboratory test, like a field exercise for judging public sentiment, public emotion, has been this entire crest and wave of COVID-19. You can see how much public emotion and public opinion, sentiment, all this is actually driving day-to-day policy making. You know, it's amazing, very interesting, but I think Dr. Faisal has it very aptly when he says, look, we have got to learn quickly from this, I mean, the cancer people, and we've got to adapt very quickly to learn how to, you know, drive policy change this way. So.
Okay, thank you, Murali. Okay, Dr. Faisal, what do you think? So we would like to know what's happening with the National Strategic Plan. Is there going to be a rollout soon, or is there going to take some time because of the COVID, the pandemic itself? We have to focus on other things, right? But how can we actually, like what Murali mentioned about human resource aspects, and I think YB Kelvin Yee mentioned about human resource planning. Is a 5-year program enough? Because I think the NCCP is meant for a 5-year direction taken up right now, because we are looking towards MOH for leadership, because I think all of us are willing to like work together. So maybe some comments, Dr. Faisal.
Yeah, thank you, Aisha. So I'm just looking at the chat box as well. So it's not that I'm trying to not discuss about management, but I think there are many platforms that talk about it. Agree, we need to spend much more money. All right, so we are not spending enough on health overall, and definitely not on cancer. But money is not the only thing. I hope people are not too focused on, you know, building X number of cancer centers, building X number of oncologists. Yes, those are important. I'm not saying they're not important, but that is the supply side. How about the demand? See, these Malaysians, with our peculiarity, how much we can drive, as in the population, the public sentiment can drive policy making. So that's one of my frustration. We in medicine talk about evidence-based medicine. Look at COVID-19. It is very frustrating as a person who, you know, we are scientists, right? All of us, I mean, medical doctors, we are all, you know, kelas science kan, bukan kelas sastra. Right, so that's one. The other thing is a balance about being pragmatic and the scope of the National Strategic Plan for Cancer Control, the Cancer Control program. It is, for me, work in progress. It is a balance between what resources we have and what's the political buy-in. And a lot of focus is still very much on the service delivery, if you see. This time around, we have extended it to look at patient survivorship, cancer survivorship, which is for me a good thing, and try to see how we can work with the civil society organizations, CSOs, as Murali have pointed out. One strength that cancer has is the CSO. If you compare that to diabetes, you compare that cardiovascular disease, you compare it to stroke, to national heart, cancer is much stronger, much larger, and I think we should leverage on that. And there are work that we can do, how we can, build on the strength of each of these CSO. Albeit cancer is not one disease, I agree. Diabetes is at least type 1, type 2, and whereas cancer is multitude of cancers. I understand that, but it is still within the same domain. So going back, I would agree with Murali's observation. Is still very much geared towards MOH, and rightly so, because we are working on limited resources, both in terms of budget and manpower. I'll stop there first, Aisha.
Okay, I think people are very interested to see about the current events, like people are not able to access early diagnosis, they're not able to access cancer surgeries, right? So how is the current policies helping? Because I think we do have the public-private partnership. I think there are clear policies that MOH has clearly it delineated like for many, many years now. But how does that affect this current issue right now? I mean, like, can it be done in such short notice? Because I think last year there was a move. I think there were some private hospitals who provided CSR funds for patients to get treated in private hospitals, cancer patients treated in cancer hospitals. We all face the same issues in public hospital. We were not able to operate on our patients. So how did the policy, was it a barrier or was it an enabler to ensure smooth,
I'll try to answer that, maybe then Murali. I don't think that's an easy answer for that. Firstly, I've always thought, and I feel strongly again, that our healthcare system is poorly suited for NCDs, for the current challenges and moving forward. So let's not talk about COVID-19. So even without the COVID-19, the fact that we have a dual public-private and the way we are funding it, especially proportion out-of-pocket payment, which is very high, that's not a good thing. So in a way, we are working in a broken system. That's first point. Second point, we do know that a lot of patients are not seeking treatment even when they can. So issue of accessibility and availability is a real thing. I mean, you did a paper, right, on breast cancer, papers accessing cancer care. So now you have COVID-19. So with COVID-19, let's talk about the earlier stage of the pandemic. For me, people who wanted treatment or wish to seek treatment will find some ways. And people who do not want treatment, it just gives them an excuse of not coming, all right? But now we are at a critical stage for COVID-19, where we see the admissions to the ICUs, people needing ventilators. So that is going up. But even then, we are not talking about the whole country as a whole. These things are happening in places. If I'm more familiar with diabetes, so let me just bring it back to diabetes. So when we talk about disruption in care, in primary care, it's not the same throughout the country. Some places, they kata, macam biasa je. We are not, in terms of service delivery, diabetes, boleh je kita orang buat screening, boleh je. So it's not like throughout the country. But now the government have to make that difficult decision of resource allocation, because we are looking at the current trajectories of other countries as well, requiring specialized, ICU support and all that. And definitely we are in a very difficult position now. And that is more firefighting, right? Ultimately, we need to see how we can stop this in the first place for next time. And I think we have enough information about this sentiment of Malaysians. I think we need to really understand the behavior of Malaysians if we want to put in good intervention next time. Definitely good strategic comm is something important. Change government, I do not know. That's something that is easy to talk about, but not easy to implement. And I'm always of the thought that let's try to do something that we can control. And for me, strategic communication is something that we can control moving on, in terms of trying to modify public's perception and build that trust. So there is a strong trust deficit right now from the public towards the government as a whole. Murali, how about you? What are your thoughts?
Yes, Doctor. Just kind of to draw this very interesting point, Prof. We were struggling. We continue to struggle with this idea of resource allocation, and what we've had is over, I think, the longest time, this big divide in the health systems between public and private. So I think, again, something that we've talked to death in multiple forums over many years. I remember we all went to Parliament and we met the entire batch of MPs, I think in 2018, 2019, and we've been talking about that as well. And what needs to be there is kind of structural allowance for example, patients to cross over. Okay, patients to be managed, like Dr. Faisal was saying, in some places the burden is not so much from COVID. That is true, and actually within internally in the Ministry of Health, there's already been a realignment of moving work away, urgent surgeries and all that, to the non-crowded centers. This was being done last year, even in May, June, July already in 2020. So, but sometimes it's not as easy to move a patient from, say, Seremban to Kuala Pilah or something. But within Seremban, we could move the person to the many private hospitals, and even have that allowance for consultants from the government sector to cross over or private to cross over. Now, all this may require a little bit of money, but more importantly, it actually doesn't cost much, in the sense that what it does need is, it needs consent, it needs oversight, it needs regulation, and these are three things that I think we've talked to death about. But again, this is not something that MOH can decide. This needs political will. And immediately, by one stroke of the pen, the emergency ordinance allows the government to seize and use hospitals for COVID-19. So when the government has that political will, when they see that urgency, they can do it. So all we're asking for is, look, since you see the relevance of using it in COVID, why not then use it in a semi-emergency setting, or however it is that you call it, subsequently for years to come? Because like I was saying, it's not that we don't have enough infrastructure, but sometimes a lot of our infrastructure is locked up, including human resource, where we can't pay for it. And all we need are these mechanisms to kind of enable us to cross over. Similarly, and I'm not kind of making a kind of a blind kind of statement here that, oh, we need to only have cancer centers in important areas, but you will always see your policymakers will kind of try to cut down costs or save on costs. So rather than thinking about always building more and more centers, I think we should talk about things like transport allowances, making sure that, accommodation, logistics, these are things that we can work out, which may be cheaper in the long run for us to kind of manage the cost of cancer patients. And none of this is medical. None of this is medical. I'm sure you all can see that. And so, there's a question from someone asked, are the speakers foreseeing more cancer surgeries and treatment being cancelled, not just because of MCO, but because of full ICUs and beds in public hospitals? For sure, because it's not even rocket science, very simple. And I'm sure Prof will tell you the same. You want to do breast surgery, in extensive breast surgery, for example, or actually thyroid surgery. The patient probably needs an ICU bed, but if I lock up that ICU bed, when I suddenly get an admission into ED who is SOB and with low oxygen, and I know this person is now going to compete for my ventilator, how am I going to have the face to do elective surgery? It's something very unreasonable for us to expect from your public centers as well. So exact policy comes back to we need grounded policy lah. And if these things had been in place and moving forward, if we can put them into place, we can help mitigate recurrences. And how we're now, as Dr. Faisal was saying, all we're doing now is firefighting. That's all we're doing, and trying to stay alive.
Yes. So I suppose there are two ways of looking at this. You have to do something in an urgent situation, and you got to plan for the future. But what the urgency is now is what I think I want to pick up on what Dr. Faisal was saying, the strategic communication with the public about cancer care during the pandemic. So that could be a very important tool, because some hospitals are open, they are available for diagnostic procedures, but we don't see people coming through to getting this type of early diagnosis. So some of them wait. I think for the first MCO, some people waited 6 months to 9 months before they actually came with a symptom of cancer, which is disastrous. I think if our National Cancer Registry showed the increase in the percentage of stage 3 and 4 in 2016, in 2020, we probably will have more. That means from 53%, it will now to what, 67% or something after the pandemic. So this strategic campaign does not require any policy change, right? But it just needs some form of awareness at the level where it is being done to actually do it. So how do you foresee, Dr. Faisal? Whose job is it to do this? Is it the CSOs? Is it MOH?
It's easy to say it's everybody's job, right? Like in the COVID-19, I mean, you see the press statement from DG, right? Everybody has an important role to play. And I don't think everybody realizes it, or see, I don't have enough information to say what Malaysians are thinking about. If we are fighting the system, you know, we don't agree with the MCO, we don't agree with the SOP, why? I think we lack that information as to the why. It's just cannot be because, are we tired? Don't we trust the government? What? So we need that information, which we are lacking. So I mean, however, those people are here on this forum most probably will be the cancer people, not the behavior scientist people. So these kind of things I would pose to the people who are doing behavior research. Going back to the first for that strategic comment, going back to the policy. Ours is a centralized government, so you know, one policy for the whole of government lah. So you can do one policy for Negeri Sembilan, one policy for Selangor. So perhaps a settings approach is a more good starting point. And the reason I'm bringing that, Aisha, is because of the City Cancer Challenge. So that is looking at approaching it beyond the health side, medical side, but looking at it within a fixed geography and trying to link all the other sectors, you know, the Datuk Bandar, the mayor, the social. It's not easy, and you know it's not easy even getting it off, and trying to get people who are outside of health to be thinking about health as their issue, even within a fixed geographical location, pun challenging, but for me, it's a good starting point. So if you can see or show success up to a certain degree within City Cancer Challenge in the Greater Petaling, and maybe somebody can post that link to the chat box for those interested to read up about City Cancer Challenge, right? That's a good starting point. All right, so going back to your question about strategic communication, I think one of the key important things is a good role model, positive role model. And we can start small, you know, you don't have to be somebody Insta famous. And this is where civil society for me has an important role to play. If you see in developed nations, they have strong civil society across, not just health, across, even in their government decision making. You will have this organization which gives the voice of the people towards decision making at the national, at the country level, even at the parliamentary level, which we lack. Okay, we don't have that. And now we're talking about health, but we have to start somewhere. And this is where I see a role. How exactly do you build a good civil society? I don't have the answer. I mean, I would like to ask people who are in Australia. Why I pick Australia? It is because their strength in tobacco control was started by civil society in the 1970s. It wasn't by the government. Suara rakyat yang menekan, yang forced the government to make difficult decisions. Whereas our voice of the rakyat is going the wrong way. We want, vape to be legalized. I'm sorry, now I'm diverging towards tobacco. Let's come back to cancer. So civil society has an important role to play. We need people who are expert in strategic communication. We need people who are expert in behavior and looking at Malaysia. I think this will be a good starting point rather than, as Murali have pointed out, we have talked about all the issues, and issues is easy to bring up, right, Murali? Ni duit tak cukup, orang tak cukup, semua tak cukup, tak ada orang nak sokong. Let's try to focus more on possible ways. I'm not saying it will work, but at least it's trying to do something which is different, which we have not attempted. So City Cancer Challenge is one, and the other thing is about how we can get civil society, especially the cancer-related society, to be positive role models models, and role models can take many forms to be the voice for the people towards the. I'm not saying you're not doing. So to be fair, okay, come on lah.
Thank you, Dr. Faisal. I think
Murali dah buat benda ni bertahun-tahun kan.
Doing every day and every night he's doing webinars, trying to get the word out. So the other thing is, I think we're almost to the end, almost 5 minutes coming through, but I think you just hit the nail on the head. The policy that we have in Malaysia is not very friendly to cancer control because, as you said, everything is centralized. Once you go to the regional centers, they have no punca kuasa tiada di regional. So for example, the city councils, they really didn't know what role they have in health care, you know. So I think this policy about having federally, controlled health policies may actually be quite detrimental to us. So last comments, Murali, you start first, and then maybe Faisal. If we have time, we just go a short while at the end with both of you. Okay, go ahead.
Okay, will do. Prof, I actually want to bring up kind of reinforce 2 points that Dr. Faisal was talking about. One is he said that everybody should be able to do something, and this positive role model idea. And I think the other idea that kind of insight that Dr. Faisal is talking about, and I think you were also saying this, is that how we need to move at many different levels. Now, 2 things on this, and I think this is really kind of where we need to all come in. Now, while we always talk about policy at the central level, but there's policies at very small local levels as well. So even on a district level, things like can we put aside a little bit of money for supporting palliative care efforts? I think because it doesn't necessarily need to come out of a health budget, you know, and that's the kind of important message coming about. It can be something that can be done. It needs to be driven. Local councillors can make these small allocations within district councils. You know, that is something that doesn't need to wait for a government parliament budget. A little bit of effort, like for example, a district council can come up with a program to help screen for cancer. We've seen now some states have taken this on. I'm very impressed with Selangor, Memocell, Penang now has a program as well to, you know, kind of pick up breast cancer early. These are not health funds operated within a health space, but they're being spent on cancer early screening and detection. Why not? Something like Majlis Perbandaran Kajang can look at some kind of small money. We throw money in for all these different reasons, but it's something that local councillors, local heroes, us NGOs on a local level can do small. So I always believe in this, and you've seen this in this small lab idea. Start a small project, kind of drive it. It works, then we can scale it up, working together with everybody. But we come back to this message of what Dr. Faisal was saying about strategic communication and how everyone has a role in that. Whose job is it? We all wait for DG punya press conference at 5 o'clock. But in the meantime, 200 times a day, we will be forwarding all the crazy WhatsApps on the phone. You know, it doesn't take much for you to stop and intervene as well. For example, have we even put out our own kind of communications plan individually, or even as the smallest society of 10 people out to that group of 1,000 people that we know, to convince them to go and get cancer screening, for example, and not wait if they're getting signs and symptoms? No, we don't. So we're still going to fall back out and wait for, DG's not saying this at 5 o'clock, minister's not saying it at 6 o'clock. I think the lesson that we all are learning is that, hey, look, we keep on shouting at the government, but at the same time, we know that the government can't do everything. I have a totally different idea of like, why do we wait for the government? We have to do this ourselves. It's our fathers, mothers, kids yang dying from cancer.
Okay, thank you. Dr. Faisal, last words.
So shout out. Okay, yeah, no worry. So it's not my pitch, pitch for somebody else. Thank you, Dr. Ednin. He continues to fight for palliative care. So palliative care is something which is overlooked, so severely overlooked. So that's my first point. Second point, comment by Dr. Amrahi talking about national health policy. I don't feel I need a national health policy. I need health to be incorporated into all policies by the government, so that you don't require health policy. That means And this happens in the UK, in Ireland, where, okay, so health must be incorporated into all policies. We don't need another document, seriously. Okay, back to you, Aisha.
All right, thanks, Faisal. So I think I'll just wrap up by saying that, well, we are looking towards what? Betterment, strengthening policies, but that's in the long term. But what we can do today is actually you and me and we can actually do something about something, right? So we don't have to actually wait for the government to tell us what to do. I think by providing, this type of discussions, I think we have to congratulate Azrul. A lot of channels of communications are open. We all learn what we can do in our spaces. So with that, I think we'll pass back to Azrul. We are right at the point of 10:50. So we are keeping to time. Azrul, pass back to you. Thank you very much for the panelists. Yeah.
Thank you, Prof. Aisha, for such a professional moderating of the session a moment ago, including a spot of roasting from Dr. Faisal and Dr. Aisha on me just now at the beginning. Love it, love it. Just wanting to reinforce some of the messages that were mentioned just now in terms of ensuring that the conversation on the care continuum is one that encompasses beyond just talking about just the dollars and cents, but also in terms of looking at what is understood by care itself, which could include both medical and non-medical factors, which requires, therefore, more of a collaborative effort with stakeholders beyond just the healthcare sector. And that would also include things like social welfare, include human resource, and even to some extent, transport would also be something of an issue as well. We definitely need to widen the kind of scope that we're looking at in terms of implementation of many of these cancer policies. So thank you again to Dr. Murali, Dr. Faisal, and of course, Professor Dr. Aisha for that session earlier. So at this point of time, we will be entering a short break, a 10-minute break where we will come back at 11 o'clock. So please do stay with us and come back for the next session, which will be at 11 o'clock on ensuring that no person living with cancer is left behind. Please do join us back again. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. Welcome back to all of you joining us this morning at the roundtable discussion on strengthening cancer care amidst the COVID-19 crisis. To those of you joining us just for this next few sessions, welcome. And for those who are rejoining us from the earlier session, welcome back. We are about to start the next session, which is on ensuring that no person living with cancer is left behind. Certainly the very people who we have been talking about for the past few speeches and presentations, and certainly we wanting to ensure that when it comes to these times of crisis, that when we're looking at this issue right now, people living with cancer and their families are not left behind. So I can think of no more appropriate person to speak on this issue than the persons who have been invited for this panel, for which they will be introduced by a distinguished individual in the cancer sphere, which is Madam Ranjit Kaur. Madam Ranjit, as many of you know, is a strong patient advocate and a breast cancer survivor herself, serving currently as the president of the Breast Cancer Welfare Association Malaysia. She has been appointed a board member of various multi-stakeholder platforms, including the Union for Cancer Control, UICC, and the ABC Global Alliance. So with that, I hand it over to Madam Ranjit. Please go ahead.
Thank you, Azrul, and good morning to everyone. I would like to now go into the what we call the survivorship space. And as Azrul mentioned, we want to ensure that no persons living or affected by cancer are left behind in this whole space of when it comes to strengthening cancer care amid this crisis that we have, which is COVID-19 crisis. A rude shock to all of us, but what can we do? We have to just work together to make sure that things are happening for all of us to continue to live life as normal as possible and have a good quality of life. So here I have a distinguished team of people, which some of you may be knowing as well. And they will actually be talking about this particular topic. And they will also talk about how have people living with cancer managed to manage their access to care and support during the past year. And also how can people living with cancer can be more involved in this whole crisis that we've been going on for some time. So the first speaker for today is, for this particular session, is Siew Boon Lui, and many of you may know her. She's the president of the Society for Cancer Advocacy and Awareness Kuching, which is in short called SCAN. She is also a breast cancer survivor like myself since 2006. And Boon Lui is a strong patient advocate, and she found this organization called SCAN in 2017 to ensure that there is a unified voice for all cancer patients to improve access to high quality healthcare in Sarawak with its dual mission of advocacy and awareness. She is a leading voice and advocate for the needs and welfare of cancer patients in the Sarawak region. Welcome to Boon Lui. Please kindly go ahead and give us some information and share with us your thoughts.
Thank you, Ranji, for your kind introduction. And I'm so grateful to Azrul from Galen Centre for having me as, so far as I see, the only non-medical panelist, but someone who has been through cancer for the last 15 years. I'm grateful to have the opportunity to share what I personally have experienced and what my society has been exposed to in this pandemic, during this pandemic. First of all, I must say that it is certainly a very huge challenge for all cancer patients to seek treatment since the onset of COVID-19 pandemic last March 2020 till now. It's been more than a year. As what has been discussed earlier, elective surgeries delay, sometimes chemotherapy postponed commencement. People with suspected lung, they were too afraid to consult doctors, visiting hospitals with the fear of possible infection of COVID-19. And as you know, I living in Sarawak, Kuching, I consider lucky because our Sarawak General Hospital here is a core treatment center for cancer patients. But it's not so much the case for patients from outstation like Bintulu, Miri, Sibu, and even the more rural towns and areas. For example, a breast cancer patient from Bintulu will have to come all the way to Kuching for treatment every 3 weeks for her neoadjuvant chemotherapy. During her fourth chemo, she had to postpone for a week because of the raising number and also the stricter SOP imposed at Bintulu by the council themselves. So that actually is the impact. And also there are cases where people are too afraid to go out to hospital and thus they delay their treatment, and then the lung may have actually evolved into very bad case. So we've seen many of these cases. I just want to relate one story. One metastatic breast cancer patient last March discovered a naughty liver tumor which grew by itself while the rest of the cancer was still considered stable, has been prompted by the doctor here to travel all the way to KL to seek advanced radiotherapy treatment, which was not available even until today in our general hospital here. So this patient traveled there on the second day of MCO 1.0, which is 18-19 of March last year. And thankfully, this patient managed to go through the treatment at the private hospital and came back, and then the monitoring showed everything is okay. In fact, this patient is actually myself. as a metastatic breast cancer, we actually went through ups and downs. Every monitoring, every 5 to 6 months, we have to go through the roller coaster of emotions. Is it going to be still stable or not? You know, and I'm thankful that I've got a very good oncologist to introduce me to immediately go to KL for this treatment, so that I can still be here talking to you to share with you this. However, I want to highlight that there's so many other patients who may not be able to have the means to travel with or without MCO, you know, to a hospital, even within Sarawak itself, to receive the patients, the treatment care that they need. However, I must say that there are some good things that has been done by our Sargent Hospital here, like what Dr. Rose Susanna has mentioned just now. Some form of telemedicine or virtual conference, virtual consultation has been done, but it could only be limited for patients with periodic surveillance follow-up, not for newly diagnosed patients who really need first-hand clinical examination. So it also took up times from the surgeon or the oncologist when the telemedicine thing is being tried out. Another good thing that we have seen is patients may not need to go directly into hospital to queue up to collect their medicine, like for example, hormonal treatment, hormone pills. So that is a little bit help for cancer patients who are on all these periodical medication needs. However, by and large, the cancer patients, the queue is still long, even though some are still afraid to go to hospital. And there are some efforts being done for outsourcing of cases to private hospital, but I think it's very, very minimum because there's no real structure put in place for that to be handled. Yeah. So if you ask me, how can people living with cancer be more involved? People living with cancer, in other words, are cancer patients. Cancer patients in the first place, how they get to know they are being diagnosed with cancer, first of all, the earlier part of the continuum or the spectrum about education, prevention, or screening has to come in. So that's why a lot of times people only come to hospital late and late presentation, as many of us have observed and already a reality in life. So I would say that cancer patients really need help and advice from doctors, whether it's general practitioners or doctors in hospitals who are treating them, to provide them necessary information about the disease once diagnosed and their treatment options, the impact of daily life, costs incurred, so that to help them to make a good decision on how they proceed with the treatment. And our patients really need to be educated, because in this part of the world, we know that people are still leaving a lot of things, the authority almost entirely to the doctor treating them. They need to know that they can be empowered and to know they have the rights to ask as much information as possible to understand their own case, to also even up to seeking second opinion, third opinion. I know some patients are afraid to ask doctors about that, worried that the doctor will be not happy because they not come back to seek them for seek their treatment, you know, from this primary doctor. So these are the level of education needed. And also cancer patients need to be educated and to be made aware to take care of their own treatment needs, and also to voice out their needs, let's say whether it's financial, traveling, the commuting, the financial burden especially. They really need to seek out help. And all what we can do as SCAN in our society, we actually came up with a helpline since last July for patients to call up, whether it's for counseling, whether it's to get more information. They really need to take the first step to call up, to ask for help, or talk to the nurses to ask for where support groups that we are available in Kuching, for example, that can help them even with lodging and how to get food and things like that. And well, back to these cancer patients, right? Well, we say they need to know this, they need to know that, but they do not know, they may not be educated. So we really need help, like what Dr. Faisal has mentioned just now. Everybody has a role to play. So over here, as a patient group, I would like to urge that doctors to educate the patients as much as possible so that they know what they need to know, they know their rights, they know how to make decisions, they know what to consider, and then they know to take care of themselves, right? And So they also need to be aware, they need to stay vigilant rather than keep telling themselves, oh, I'm so afraid to go to hospital, I want to delay my treatment, I want to delay seeing my doctor until much later. It's been 1 year and 2 months. If that much delay has been given, then I would say if cancer patients with unstable condition, I can't imagine how bad the situation would go. So we really need help from doctors, healthcare professionals, to give the patient as much education as possible when they are in the hospital. Tell them and let them know. And also tell them as best possible who are the support groups, who are the patient groups who can help them, and the number and all this. We make posters everywhere, we publicize everywhere. Even though the number of calls we receive are quite limited, but it really tells us the magnitude of issue that actually cancer patients are facing, not just physical problems, medical condition, but also issues related to mental, psychological needs. Some patients may have appetite issue, they went to see dietitian and realize there's nothing wrong with what they try to eat, but it was just psychological. So the spectrum of issues within cancer patients is not just the cancer itself, it's so much more than that. What our panelist earlier has mentioned, social economy, psychology, education, empowerment, all these have to come in. So as much as we can as cancer advocacy group in Kuching, we try to reach out to people to do more awareness. But I think another important aspect is a partnership with Ministry of Health, like Sarawak General Hospital. We make known to all the doctors there about our service of helpline. We make friends with everyone in doing the cancer care, even in private hospitals. So we really need to work together. And also pharma companies can come in to support. And yeah, everybody just have to come together. So you are talking about how to get people living with cancer be more involved. They also need your help as doctors, as patient groups, as scientists. We need a lot more strategic communication. And also their fear over vaccine, whether they can get vaccine or not. They may not have enough that gone down to all ethnic groups, like for those who are Mandarin speaking, they may not get enough information. English speaking may be okay. BI maybe, I do not know. But more strategic, formal communication, I think it has to come from, to be led by MOH, and then we can do the cascading down. Yeah, so this is what I see from my perspective. Back to you, Ranjit.
Thank you, Bunli. I think that was very inspirational to hear from someone who's been through the experience of breast cancer, or even the experience of cancer, and from your perspective. We will need to come back to you later on for some questions and answers, and I do urge people to write in their questions in the chat box if you have any. And without anything else with you, I would like you to take a seat back, and we will come back to you with questions, to give some insights. Now I move on to the next speaker for this particular session, and she is none other than Dr. Nur Nadiatul Ashikin Bujang. And when I read about her, I said, my goodness, there are such people who are so helpful. She is the Assistant Secretary of CORAM, which is the Colorectal Cancer Survivorship Society of Malaysia, and a physician training under the Doctor of Public Health program at University Malaya. And she joined CORAM last year and found her passion in getting more involved in organizing monthly webinars and psychosocial support groups. Her current research aims are to understand the needs of colorectal cancer patients in Malaysia. So let's welcome Dr. Nurul Nadiatul to give us some information, to share with us her insights. Over to you, Dr.
Thank you, Ms. Ranjit, for the warm introduction. So I prepared slides, so I would like to share my slide first. So, okay. So yeah, thank you everyone. So I'm actually representing President of CORAM, which is Datuk Dr. Mahishinda. And I would like to take this opportunity to also thank the organizer for inviting us to be part of the discussion today. So this is my outline of presentation, where I would like to also take this opportunity to introduce about CORAM and also address the question that was mentioned by Ms. Ranjit earlier on. So yeah, we are currently in panel 2, ensuring no person living with cancer is left behind. Okay, so for introduction, so some of you might not familiar with quorum. So I just will explain briefly about quorum and what are the activity that is conducted by quorum. So basically, quorum is the only and official voice in Malaysia, specifically for colorectal cancer patient and survivor. We are established in 2030. We are a non-governmental organization that is registered under the Registrar of Society. So quorum aims to actually improve the quality of life of those affected with colorectal cancer by providing psychosocial support and information to the patient, to the family, and as well as the caregiver. We also in our activity, we also promote the importance of screening, importance of early investigation among the public. I would like to also just share, this is the main backbone of quorum, which is our president is Dr. Mahasinda, and our secretary, which is also the project lead for our main activity of psychosocial support, which is Ms. Wong. So this is the activity that we conducted under quorum. So mainly we have supportive care, we have psychosocial support either for individual or also for group. So for the activities under quorum, I would like to share here because I will explain to you later why I need to mention about all this activity. And we also have this public education and awareness. We do volunteer training and development as well as advocacy role where we write to the media and we talk to the media about all the activities that we conducted. And quorum activities are actually in line with the National Strategic Plan for Cancer Control. So now this is based on the previous cancer control strategic plan, where with the aim to reduce the negative impact of the cancer patient by decreasing the morbidity, mortality, and to improve the quality of life of cancer patient and their family. And they also outline the needs to actually address the psychosocial needs of the patient. And as an NGO, they outline the role of NGO, non-governmental organization, to facilitate self-help program and patient support activities. Okay, so back to the question, how have people living with cancer managed their access to care and support during the past year? So COVID-19 pandemic, we know that COVID-19 actually affects globally. It is overwhelming the healthcare system, affecting the healthcare system globally, and also resulting in the interruption of the usual care. So, and we know that most of the center face challenges in maintaining the same level of care as before the pandemic. And therefore, they might probably reduce or adjust their services to different degree. And using, to different degree using various approach. And for, in Malaysia, we had our first COVID cases. Just recall our first COVID cases was in 25th of January, and our first MCO was announced in 18 March 2020. And patient actually complained, especially during the first MCO, that they face challenges in terms of the treatment, where they have a problem getting a hospital appointment and hospital admission, where with more stringent SOP, they are not allowed to have their caregiver together with them in the ward, and they are not allowed to have someone to accompany them, and some of them might need to travel, and there are issues with all the surat kebenaran to travel and things like that. And some of the patients also face challenges in terms of financial, not just about the payment to the hospital, but also financial in terms of the logistic, where they need money to travel, and some of the patients has lost their incomes in this challenging COVID pandemic. So other than that, some also face challenges to actually go to see their counselor and for psychosocial support and also for their rehab. So, but I could say that as the pandemic evolved, we gain new knowledge and adjust some older approach. We are adjusting to the new norm, to the new healthcare management, I could say. So in general, there are improvements. So a good job to the Ministry of Health, and I can say all the private center also did a very good job. With this new normal of healthcare, patient actually mentioned that they themselves could see improvement in terms of assessing the care. and they know what to do, and they become more informed of the things that they should do. And with as we know that when we understand the nature of the disease itself, of the COVID, by ensuring and complying with the SOP, the patient would actually minimize the risk, and they become, like mentioned by our speaker, Ms. Boon just now, that the patient themselves become more empowered. So from the patient perspective, how they manage access to care. So when they become more empowered, they themselves call for help when they have any uncertainties or they need any opinion. So I could say that I think each and every one of us are affected by COVID-19. So people who have survived cancer, at time they face this unprecedented fear and anxiety of COVID, right? But like I mentioned just now, throughout the pandemic, people are more aware of the nature of the COVID-19. So they follow more stringent SOP. And this actually help the patient to actually gain more confidence for them to go to the hospital. So like Ms. Woon mentioned just now, I think some of them also told us that they are afraid to go to the hospital. They're afraid that if they go to the hospital, they might get COVID if they just pass by through patient with COVID. But with the current knowledge, and by explaining to them on the nature of the disease and transmission, they become more aware. And I could say that when the patient is empowered, where they call for help, it's actually good, where they can exchange idea or experience. So some of them from different hospitals, they might have better knowledge in terms of who to contact, what are the nature of the appointment, or probably like as example in PPUM, you can access through their website. There's a lot of information and things like that. So all this networking that we have, some of our patients, they contacted us through Facebook, and we have this WhatsApp group where all the patient and also caregiver, we include caregiver as well, they can exchange all this information. And with all this networking, they find it very helpful, because some of them might even able to contact the stoma related person when they have issue. Yeah, and if let's say they have issue with purchasing the stoma and things like that. Okay. So yeah, I would like to share about the supportive care program that Quorum have conducted. So Quorum has shifted our activity from face-to-face to make it actually more accessible to our patient. So we understand that the patient and some of our support care volunteer, their support is they themselves are survivor. So we don't want to, we want to minimize the risk. So by that being said, our previous supportive care program, we conduct this supportive care program under Quorum in Klang Valley. It involves hospital like HKL, Hospital Selayang, and PPUM, where we go to the hospital alternate day every week. But after, prior to COVID-19, it was only a face-to-face session in the hospital. But during COVID-19 pandemic, we have the initiative to shift our support care program from face-to-face to initially hybrid program, where this hybrid program, initially we actually facilitate the nurses on how they could join the session, and how the nurses themselves could then facilitate the patient to join the session. And for now, we had shifted our program to fully virtual program. Okay. So this is just some of the picture of us, and we also send out invitation through our Facebook, and we also share through WhatsApp group. And I believe most of us also aware that we have not only Quorum, a lot of NGO, a lot of organization had organized a webinar, virtual webinar. And I believe the other organizations are doing the same thing. And I would like to say that, like mentioned by Prof. Aisha, I also tuned in the session that conducted by NCSM with Dr. Murali. So thank you to Dr. Murali. Actually, my patient, the in quorum, we also find it very helpful and beneficial, especially you did a session on vaccine, I think a webinar on vaccine, and you take the initiative to talk in Bahasa Melayu, and your Bahasa is very superb, I could say. So thank you NCSM for that. And we received a lot of good feedback for the session that is conducted by NCSM. So moving on to the next question on how can people living with cancer be more involved? So to answer this, I would actually like to quote a saying by Prof. Adiba. We need to look at care from the perspective of patient, not through the lens of our own predetermined silo. So that being said means that we need to talk to the patient to understand and assess their needs. So the voice of the patient matters, and we need evidence. So I believe to achieve this, research is important. So before I move on to why research is important, I would like to share this one slogan that was also shared to me by my academic supervisor, which is Prof. Nimala. Nothing about us without us. So this slogan is actually used to communicate the idea that no policy should be decided by any representative without the full and direct participation of members of the group affected by the policy. So again, emphasizing that the voice of the patient matters. So for research, that being said, I would like to share the research that Quorum collaborated with a team of research from University of Malaya, including myself under the supervision of Prof. Nirmala and also Prof. Awang. And it is actually an umbrella project called Living Well with Cancer. So we are actually advocating for person-centered research. And echoing what Dr. Faisal stated earlier in panel 1 discussion, with the advancement of technology, with the increasing number of specialists, we have today actually the number of cancer survivors are increasing and cancer survivors are living longer. Thus, it's actually important to understand the needs of this patient in order to make the patient live better, to improve the quality of life of the patient and to improve the accessibility of cancer care of the patient. So basically the research that I conducted in collaboration with Quorum is the development of needs assessment. So this needs assessment, we developed a questionnaire with this questionnaire, we would like to determine the prevalence of needs among cancer patients, specifically among colorectal cancer patients in Malaysia. And what are the factors that actually affecting this, the needs of this patient? So, and the needs that we are talking here are other than medical needs, like the psychosocial needs, the financial needs, the practical needs of the patient. So I believe some of my colleagues here also working together with BCWA. So Ms. Ranjit might also familiar with this topic. So also thanks to BCWA for the good collaboration that I think we have with the research team. So, and I believe that this collaboration and also partnership is important, and it is actually an example of the importance of multi-sectoral collaboration for the benefit of the patient. So I only have a few more slides. Please bear with me. So
we're almost up, so maybe if you can wrap up your...
Okay, sure. Okay, sure. Only this one, another two, only short one. So translating research into practice is important. So for the research potential, having the knowledge about different needs of survivors are actually critical in guiding where we can focus our limited healthcare resources, especially during this COVID-19 pandemic. And this evidence could actually further advocate the importance of the needs to addressing the needs of cancer patients and to address okay, sorry for that. Okay, so basically data is important for planning and for the implementation with and most importantly with multi-sectoral collaboration. So in conclusion, by understanding the issue and the needs, by identifying the needs of cancer patients, this will actually facilitate in designing the accessible cancer care, not only during this COVID-19 pandemic. So key policy changes should also include innovative strategy based on resources and capacity to cater for the different needs of cancer patients. Okay, Ms. Ranjit, thank you. I did speed up the last few slides. Yeah.
Thank you. Thank you very much, Dr. Nur Nadia, for keeping up to the time.
Okay,
And
thank you.
we now move on to some questions and answers. Both of you spoke about, I mean, Nur and Nadia, you actually spoke a lot about how patients are supported in quorum itself, and also the needs of patients. Now, the question here is that we talk about patients being the recipients of services, and also we talk about them. We know for those of us who've experienced cancer ourselves, when we're newly diagnosed, we also go into this situation where we want to speak to someone who's been through the experience of cancer, of the same kind of condition. And we sometimes tend to look for people that we get some support from them, and we call that peer support. So I wanted to ask both of you a question here that, you know, how do you handle issues where patients actually who are newly diagnosed go to friends, friends of friends, relatives, and people in society, and they try to look for answers which give them hope? And what do you think are the influences sometimes for them to seek the right kind of support? And where can they get the right kind of support? Because you need to have the CSOs to be connected to the healthcare services. And also the other thing is the healthcare services, when we come to healthcare professionals, they need to have trust in us as to whether we can be trusted as peer volunteers to be able to give the psychosocial support. So if you would like to talk a little bit about that, maybe I give to Bundui first, then I'll come back to Nur Nadia too.
Yeah, Ranjit, thank you for that. In fact, even though we only receive a minimum number of calls from a helpline, we actually got a lot of referral from our network, the circle of friends, relatives, and so on. So I would say it's been like 30 to 50 referrals been given to us. And many of them, knowing that we've been through cancer, they feel much more open to share their worries, their queries, and their emotions, especially female patients. I would say majority who actually seek help are the female patients, whether breast or other types of cancer. So for example, breast cancer patients are those who actually come to me the most, knowing that I've been through that. So, and also at the same time, what we do is we tell them what we've gone through. We told them the frustration that we've gone through when people give us too much advice outside of medical professionals. And we told them how we finally got to the right reliable websites, reliable information and references. And we also end up making a book, publish a book, a cancer guide with some reliable website reference, some very basic information about diagnosis, how to cope with emotions, how to seek support, including logistical and even financial. Even though, as you know, in Malaysia, apart from so-called heavily subsidized treatment, patients from outstation may not be able to do so. When they come out all the way for like a week of treatment, they lost 1 week of income. So we tell them that they can go to this organization, this welfare, or maybe this support group who may be able to provide some level of subsidies. As far as doctors are concerned, we point them actually always to general hospital plus private hospitals, medical professionals that we know. So that, and we tell them that when patient is sick, you need a doctor, right? And we don't become a doctor by ourselves unless you happen to be a doctor by not diagnosed with patient. So that is the advice that we tell them. However, a lot of times because of influence of the culture or the kampong or whatever, even in the people with highly educated background, even lecturers, it happens that people who delay the treatment, they are in denial stage for a long time until the pain really comes to them. They have no choice to go to hospital, but within a few months, I'm so sorry that they just couldn't sustain anymore. So that happens. So what I would say is we do our part to educate, to share, to refer them, but the patients have to make a decision for themselves. What is the best care for them? That is evidence-based. Yeah, and hopefully they really read our book when they get one. Yeah, That's from my side.
But just a little question here about the trust that healthcare professionals need to have with cancer survivors. Is there some form of training that cancer survivors get so that they can offer support, psychosocial support? Like you also mentioned a little bit about navigating them to resources. Where do your people get training from for providing psychosocial support? And
so we call ourselves volunteer counselors. What we did was we had some so-called brief training under our medical advisors about cancer, about basic treatment, because some of us may not have been through the whole string of treatment, so we may not know anything about radiotherapy. So we went through basic so-called cancer treatment 101. And then we also engaged a psychiatrist to lead us how we can train ourselves to be good listeners. Very important to be listeners. And also to direct the patients, to help them to make decisions by themselves. However, still providing the avenues where they can explore. Yeah, this is what we've been. And it's actually a lot of times on-job training. And we learn and we share our experience with one another non-stop. Yeah.
Thank you, Bun Lui. Dr. Nur Nadiatu, would you like to share a little bit from your perspective of providing peer psychosocial support and navigation, whether these survivors do get training? I mean, both of you spoke about using social media and maximizing it, not just for the psychosocial support, but also to have virtual consultation with the doctors as well. So would you like to speak a little bit about peer support volunteers, the trust between them and healthcare professionals and their training as well?
Okay, thank you for the question, Ms. Ranjit. So for Quorum, we have it's supposed to be an annual volunteer peer support, what we call that workshop that we conducted in collaboration with the surgeon and also the nurses, especially the stoma nurses. So we have our the head of our psychosocial support committee is Ms. Wong. So she's been in, I think, Ms. Ranjit, you probably know her. Yeah, she's been in the field for quite a long time. She herself is a trained stoma nurse, and most of this I learned from her. So basically, when we are in the psychosocial support, we have volunteers, our previous volunteer that they attended the workshop, and we also have new volunteers basically. But yeah, I could say that the COVID-19 pandemic also affect our workshop as well, but we plan to conduct a workshop this year with online workshop, probably hybrid, but we need to look at the situation. But yeah, answering your question, we have training for our volunteers who is also our survivor. And also to address your earlier question on probably some of the patient, did they trust us? So being in my position, I am wearing two different hats. But usually when I'm in the psychosocial support group or during the discussion, most of the time I did not address myself as the doctor. I am addressing myself as someone that they can talk to, because some of the patients, they tend to keep line between healthcare profession, between their doctors, and they don't want to tell about other things besides their medical needs, because they think that the doctor might be too busy to understand or things like that. So yeah, Miss Boon, I saw you smiling. Am I addressing the right issue? Yeah, okay. So and that's why Quorum also open to caregiver. So some of the patient, they don't want to discuss with their caregiver about the challenges that they are facing, because they don't want to feel that they feel that they are burdening the caregiver. So some of the patient or the caregiver, they themselves join the session. So they think that what else that they could do for their mother or for their sister or things like that. So I think especially during this COVID-19 pandemic, having a psychosocial support group or support is important. And some of the patients tend and prefer to talk to stranger about their feelings rather than someone they close to or rather than the healthcare worker. So here we are, but we are providing, I could say, we do not like, I sometimes I also monitor the other Facebook group for cancer patient, especially colorectal cancer. So, but good to know that other cancer group that also did, I could say that it's actually a good platform for them to discuss with their peer, like you mentioned just now.
Thank you very much.
Thank you, Ms.
And
Ranjit.
we have one more question that we are closing now. Do your organizations give financial support? There's a question in the chat box. If you could just tell us yes or no.
For Quorum, no.
And Bunlui? No.
Yeah.
Okay.
What we try to do to give some little gift to patients occasionally.
Right.
Yeah.
And I did hear you say that you do give resources, you do tell them where to go, which is you navigate them to other resources. Thank you very much. Thanks to both of you for your very inspiring sharing. And I will now thank the listeners also, and I hope all the questions were answered. And over to Azrul now. Thank you very much.
Thank you.
Thank you, Madam Ranjit. Honestly, it feels like it needs to go for...
Stop calling me madam, I'm just Ranjit.
Okay, Ranjit. Well, you know, Ranjit, it feels like we have to go for a full forum on that, you know, like several sessions just on the issue of survivorship. And certainly when it comes to people living with cancer, it's such a multidisciplinary, multifaceted issue. And you know, we were just touching at the very end just now on the financial support that's possibly needed. And this is something that is very much a concern, especially during this period of COVID-19 with this crisis, which is affecting not just in terms of medical care, but also non-medical as well. So this has a real implication in many people's lives. So thank you very much for that skillful moderation of that session just now, Ranjit. So for the next session, we have on this issue of looking at data. And this is something that over the past couple of months, we've seen quite a bit of discussion concerning the use of data to guide decision-making, especially when it comes to COVID-19. And we have, very fortunately, quite a number of established individuals who have been able to work in the cancer space, to be able to work in improving on how we understand about cancer, not in terms of just looking at the clinical data, but also the socioeconomic data and understanding on how we can respond better and be guided by that. So today, there's a lot of discussion about real world evidence concerning the use of COVID-19 vaccines. But today, for this morning session, we have with us 3 individuals who will be talking to us about what does the data, the research tells us about cancer care in Malaysia. So to chair this next session, I will hand it over to my colleague, Ms. Winnie Ong, who is a research officer with the Galen Centre for Health and Social Policy. Many people don't know that she's actually also a registered pharmacist and was until a couple of years ago working in a government hospital. So without further ado, I hand it over to you, Winnie. Go ahead.
Thank you, Azrul, and thank you all attendees for joining us here today on a Saturday morning. Welcome to panel 3, what does data tell us about cancer care in Malaysia? So we have a very exciting panel, and I do welcome your questions and comments on the chat box. Is Professor Teo and Dr. Diana with us? Yeah, so while we're just waiting, the delivery of cancer care is complex, and using data for decision making is not unfamiliar, from individual level like labs and all the way to community, excuse me, community level like district health data, and population level data from the National Cancer Registry. So data collected doesn't mean that data is used or accessible or that it is what we need. It has to be translated to be understood and fed into initiatives or solutions. So in cancer care, we are not just talking about demographic and clinical data, but also social care and employment and indicators for programs that we want to implement at a community level to close gaps. So the format of this panel, we will hear from our three panelists before proceeding with a short Q&A. It gives me great pleasure to welcome our first panelist, Professor Datin Paduka Dr. Teo Soo Hwang, who is the Chief Scientific Officer and the Acting Head of Community Outreach at Cancer Research Malaysia, which is a non-profit cancer research organization. It is currently focused on cancers that are common in Asians, developing new methods to screen, prevent, and treat cancers. And I think a very notable aspect of Cancer Research Malaysia is the leadership in efforts to remove barriers from high quality care, such as through patient navigation and mainstreaming genetic services. So without further ado, do allow me to pass the floor to Professor Dr. Teo.
Thank you, Winnie, for that very kind introduction. And thank you, Azrul, and for all of you for spending time this Saturday morning with this session. Winnie, I'm going to have to ask you to do me a favor and share the slides from your side because I'm having a lot of computer problems today. My computer has already crashed 4 times this morning, so it's a bit of a disaster. Hopefully we get through the next 10 minutes without me suddenly logging out. So would you like to share the deck, please, Winnie?
Sure, let me pull that up for you, Prof. Teo.
Thank you so much.
Thank goodness your computer survived for our panel.
Well, we'll see how it goes. If you can perhaps share the second deck of slide first, the V2, and then we'll do the first one. Is that okay? So to set the context, as Winnie said, we have worked in partnership with the Ministry of Health to set up something called the Patient Navigation Centre. So the Patient Navigation Centre is built within the Ministry of Health hospital, and it's a one-stop center where patients come to resolve whether they have, whether a suspicious symptom is due to cancer, and from the diagnosis of a cancer lesion, going through the treatment options and so on, making sure they complete their treatment. So within, when the first MCO hit us, we did a survey to really evaluate within our 4 patient navigation centers, what is the impact of COVID on the cancer patients as well as their treatment. Bear in mind that this is a survey that was done for the 4 centers and may not reflect all of the Ministry of Health hospitals because these were 4 major treatment centers in Klang, Seremban, Kuching, and Kota Kinabalu. So what we tried to do was to do 3 things: describe the willingness of patients to attend hospital appointments during the MCO, to understand the impact of the MCO on patients, and to be able to describe the factors associated with crisis during the MCO. We felt that these were really important to be able to work in partnership with our doctors and our centers to make sure that we could improve services. Next slide, please, Winnie. And the headline item that we would like to highlight would be that 1 in 4 of the patients surveyed were deemed to be in crisis. So a large majority of them were impacted emotionally by COVID directly. And what was surprising to us was 2/3 of patients actually lacked access to basic needs. So they were in crisis from just not having food in the fridge and so on. Of course, this was in part because the first MCO was really much more severe than the second or the third MCO. And I think these have partially been alleviated during the second and the third MCOs. A significant proportion have been impacted financially, and this is, continues because the majority of the patients that we serve in the 4 centers are in the low income group. And finally, a large number had logistic challenges needing information on COVID-19. And these were information that we then provided through telephone counseling. Next slide, please. We went on to identify who were the ones who were more likely to be in crisis, and I suppose these results are really not surprising in a sense. They are very much common sense. So patients were 3 times more likely to be in crisis if they were from a low-income group. The role of a carer is really important. So if there were carers that they were able to live with, then patients were 5 times less likely to be in crisis if there was a carer nearby. And because of the MCO, this really exacerbated individuals who are living alone because they were not able to get any care and help. Half of all patients reported that they needed help during the MCO, and this was obviously highest among those in the lower income group. And the most support that was required within the Patient Navigation Centre was certainly in health and treatment advice, and was very much valued that if this was able to be offered through telephone services. Next slide, please. So through our Patient Navigation Centre, this is just a picture of the key individuals at the centre in Klang, but as I mentioned, we now have centres in Seremban, Kuching, as well as KK. I think what's important to note is that this is really a partnership model. The role that Cancer Research Malaysia plays here is, of course, as navigators, we are training our navigators to provide services, but we're also working in partnership with the Ministry of Health to be able to roll out the hospital-based services. And we work in partnership with a large number of community partners, NGOs, cancer NGOs, or otherwise, social welfare organizations to be able to provide support and real help, either financial or logistic or otherwise, for the patients themselves. Next slide, please. So this is a summary of what we do, which is really to reach out to underprivileged individuals, to overcome the barriers in timely diagnosis and treatment. And because we believe that this is one of the biggest aspects of being able to prevent deaths in Malaysia, or unnecessary deaths in Malaysia. Next slide, please. So in terms of story, I think just 2 vignettes that I wanted to share with you. The middle part, this patient really said that this MCO was a time of extreme turbulence because people, the son who she was dependent on, really had financial difficulties, and that made it really difficult. And at one point, the fridge was just had bottles of water and not very much else. So we were able to help by making sure that we actually have basic delivery. And in a sense, you would wonder why, this is necessary at a time of crisis. What sort of healthcare service is this? This seems more like social welfare. But we found that actually social welfare is often the way of building trust with a patient, because we were thinking about it from a patient perspective. It's about their immediate needs that need to be served first, because before we can build the trust to be able to help them in decision making on what treatment options they should have, what they should be considering in terms of whether to go for alternative medicine, herbal therapies, or no therapies at all versus cancer treatment. I think if you're not there with them to provide the things that they need more immediately, it's actually extremely difficult to continue to build that trust. Next slide, please. This is the second vignette to be able to kind of describe that, what we did wasn't necessarily to provide that direct support, but sometimes to be able to navigate patients to the necessary support. And these are services that are also offered by other NGOs, as described very nicely by Bunbui just now, also offered by BCWA, NCSM, MAGNA, and many others. But I think it just highlights, what are the important considerations from a cancer control point of view. It isn't just about delivery of healthcare services and delivery of oncologists as well as targeted therapies. Oftentimes it's about the holistic, making sure that all patients can get access to the basic things that they need before they can actually look at their healthcare needs per se. Winnie, at this point, I'm going to very quickly just thank our donors, but also and partners, but also move on to really tell you a little bit about what that tells us about the bigger picture, right? So now that we know a little bit about the effect of COVID on cancer patients, how does that fit within our bigger picture of understanding what we must do to be able to continue to improve care for all cancer patients in terms of our cancer control planning perspective? What are we doing with data at that higher level? And what must we do to be able to continue to improve? So this question was, what does the data tell us about cancer care in Malaysia? And I've tried to put it very simplistically at a high level, and I hope that this will set the tone for some questions moving forward. So 3 things that we know. Cancer incidence is rising, cancer survival is rising, but the cost of cancer care is rising very rapidly, much faster than the incidence and the survival. So of course, in terms of the Malaysian context, we know incidence from the National Cancer Registry as well as the now National Health and Morbidity Survey, cancer survival from MyScan and other hospital-based or population-based studies, and of course from cost of cancer care from the ACTION study. Next slide, please. What we also know is, and this comes from a lot of data, not just from Malaysia, but internationally, is that the good news is about the proportion of preventable cancers, that new therapies are constantly being developed and that Malaysia has universal healthcare. But the bad news that we often don't talk about are that we're still struggling to deliver timely surgery and radiotherapy. And the bad news is, of course, that funding is unsustainable, not just for Malaysia, but we just had a discussion with the Asia Pacific Network for Research, and even a country like Singapore describes cancer as the most unaffordable disease moving forward, because whereas other cost of other diseases is increasing at about 2 to 5% every year, cost of cancer treatment is increasing. The CAGR is at about 20 to 30% every year. And that's a very, very frightening number. Next slide, please. So what we really don't know at a system level, if we were to compare to think about the data that we are trying to collect or develop, is to try and understand what interventions can we actually design that are cost effective, that would really make a difference in cancer incidence. And I think we really need to face the music, if you like, and ask ourselves, how much do we actually know about the interventions that really work? So of course, Project Rose is an amazing effort to try and go out there and put self-diagnosis or self-sampling for cervical cancer in the hands of women, and hopefully be able to determine whether this can actually improve the screening for cervical cancer and enable early detection of cancers and maybe even pre-cancers before they become cancers. We're very delighted to be part of a new project in collaboration with University Putra Malaysia that's trying to determine whether interventions such as web apps that are being rolled out in primary care settings may be able to inform and educate the public in a way that systematically encourages uptake of screening. But when we talk about primary prevention, there's a lot of effort, but actually not a lot of data on impact. And we really need to figure out at the national level, what are the opportunities for us to be able to intervene, to be able to reduce the incidence of cancer and potentially reduce the delays in presentation. And then I've put two big question marks next to what do we need, what are the gaps in terms of cancer survival as well as cost of cancer care. So in my opinion, what is really lacking at the moment is we do not know, or we do not have a system by which we can make decisions on what treatments we want to pay for. And unfortunately, that means that we're now stuck in the position of lobbying for a bigger budget without really necessarily having the evidence base of saying, should we be paying for a few treatments, very expensive treatments for very few patients that result in a very good outcome? Because it's very good outcome, we can save those individuals? Or should we be going for the masses? Should we be giving a therapy that is cheaper, but more accessible to a lot more patients? If both of those are equal cost, of course, we'd like to be able to buy both. But in a system that can't afford both, how do we make decisions on what treatments do we pay for? And I think as a country, we currently have not made that decision. And this is a policy decision that's screaming to be made, because without making that decision, it's very hard to see how we can move forward in an equitable way, and how do we measure success? How do we know, whether we're making any success because we're doing it in a piecemeal fashion? And the third question that I think we really need to think about from a system point of view is really, how are we dealing with the cost of cancer care? How do we build a more sustainable financing system? There's been a lot of talk about a national insurance system, for example, and that may be inevitable, but it keeps getting derailed either by political will, or by the changes in government, or by the public's appetite to consider something like that. Next step. And I think what we also don't know is really the patient's voice. You've heard some of that and vignettes of that from not just the first session with Dr. Murali as well as Dr. Faisal about behavior change and so on, but also from the second session from Ranjit and Bunlui and from Chorus. But I think what we don't know is, how do we take what patients tell us to develop interventions that can actually help more patients moving forward. So for example, we now know that most people in the public do not want to talk about cancer. They do not want to engage in screening for cancer. It's something that they would like to avoid. But have we asked ourselves what interventions actually work? Is it just about organizing more public talks? Or is it about making screening actually available? How do we know how to convert the belief systems that the patients have into intervention systems that actually work? In the space of cancer survival and decision-making about treatment, we're starting to make some impact by developing decision aids that help patients understand what are their treatment options, what values are important to them as patients, that help patients make decisions about the treatment options that are appropriate to them, and not just leave that decision making to the doctors. And finally, in terms of cost of cancer care, we really don't know enough about patient perspective, and we're not doing enough work to really work out how can we involve patients more in decision making on being able to afford healthcare in the long term, not in our generation, but in our children's generation. I hope what I've done so far in this second part is really to give a high-level overview of what data we have at the national level, perhaps some of the data that is missing at the moment, and what impact that might have in terms of what we must do in order to be able to have an improved overarching strategy for cancer control and improve survival in our country. Thank you very much, Winnie. Back to you.
Thank you so much for that, Professor Teo. So I think that just sets us very nicely for the next presentation. Data is not just what we know, but also what we want to know in order to focus our limited resources. So our next panelist will be speaking about how data is being used to build greater preparedness for our cancer care system during COVID-19 and in the future, in the next year or so. So I would like to introduce Ms. Teo Su Peng, also known as Corinne, who has served in the Ministry of Health as an instructor in medical lab technology before embarking into public health. Her research interest lies in improving health services, particularly emergency preparedness for cancer care in hospitals. She's currently in the second year of her Doctor of Public Health training, so I do thank you for taking time from your schedule to join us here today. And we look forward to your sharing. Pass it over to Corinne.
Thank you, Winnie, for the kind introduction. Just to check, is my slides visible to everyone?
Yes, and if you could have that in slideshow mode, that would be great. Excellent.
All right. Okay. I'm really honored. My name is Corinne. I'm really honored to be invited to speak in the same platform with so many distinguished experts here. I would like to extend also my special gratitude to Associate Professor Dr. Nirmala for this opportunity. Today we are excited to share our research project on co-designing a guideline to maintain quality cancer care during and post COVID-19, which is really relevant in the current situation. The COVID-19 pandemic, as we know, has brought along a whole lot of changes, be it economically, socially, psychologically, or even financially. We already know that the direct health impacts of COVID-19, which is the morbidity and the mortality related to the disease. What we don't know is, or what we are trying to know more is the immediate indirect impacts on other patients needing health care, specifically patients currently receiving cancer care. The impact on cancer care is very obvious, as mentioned by so many panelists before this. In terms of patient care, globally, we are seeing decrease in the diagnosis of 6 most common cancer types: breast cancer, colorectal, lung, pancreatic, gastric, and esophageal cancers. And many of the speakers has also talked about how people with potential symptoms may have delayed seeking medical advice for fear of being infected. So along with the social isolation and occupational challenges associated with the movement control order we have 1.2, 1.0, 2.0, and now in the MCO 3.0, and as well as the travel restrictions, COVID-19 pandemic has impacted patients and caregivers psychologically. And with relation to the oncology management, we observe increase of patient load in cancer care facilities after the MCO 1.0, concerns on how quickly the backlog will be cleared and whether or not the pandemic has caused an increase in late-stage cancer or higher mortality and morbidity, that remains to be elucidated. We are already seeing the harmful impact to cancer services resulting from the pandemic, and the effect is expected to last across the entire cancer care continuum. Now, in terms of the administrative impact, cancer research and clinical trials are also affected with disruptions in patient recruitment, funding restrictions, change in protocol, and also a significant drop in new cancer drug trials. Just skip this because it has been covered by the panel. Here are just some of the tips of the iceberg. A few days ago, our health DG has sounded the alarm that our hospital capacity is already reaching its maximum. This is bound to affect the management of elective procedures in cancer care, such as colonoscopy. But what we are hearing are only the stories of those infected with COVID-19. What is not heard is the story of patients with other diseases who may have lost the opportunity to receive care because their hospital is a hybrid hospital, and and it is overburdened and stretched beyond capacities. Nevertheless, the negative impact of COVID-19 is not only experienced in low and middle income countries like as mentioned, but also in high income countries. As we can see, Singapore has announced officially in their news portal that the hospitals are to defer non-urgent surgeries and admissions to conserve resources as COVID-19 cases arise. This is why a crisis preparedness plan will be so important, because we do not want to come out of this disaster without learning anything. A recent report by the Economist Intelligence Unit defined cancer preparedness as how well countries are prepared to achieve major reductions in premature death from cancer, increase cancer survival rates, and improve quality of life of survivors. And the report also measured cancer preparedness using indicators from these three domains. Our research focuses on the continuity of cancer-specific healthcare delivery in tertiary hospitals in the Klang Valley. And we would like to propose that all hospitals should have an emergency preparedness plan in place for cancer care, which is frequently reviewed and updated with or without crisis. This figure just shows that the cancer care occurs on a continuum from prevention to treatment, survivorship, and palliation. We all know that the path is not linear, which means that not everyone stops at each point or spends the same amount of time at each point. Therefore, while developing this emergency preparedness plan for cancer care, we involve as much cancer patients as possible, the healthcare professionals, the NGOs, the policymakers, to inform options and actions at each point in cancer care. We also collaborate with multi-sectoral stakeholders along the continuum. Some of the speakers here are our collaborators, Dr. Faisal, Dr. Rose, Dr. Murali, to develop a feasible guideline that can be easily adapted into the current health system. And specifically through our co-design method, our work also provides a platform to incorporate the experiences and perspective of cancer patients during the design of the guideline. Yes, as the panels in the second session mentioned, no one should be left behind, and these include the private, including the healthcare private private healthcare systems. So rather than turning to them only in times of crisis, the current pandemic also teaches us that the engagement with stakeholders must be proactive. This means that we must build sustainable partnerships even when there is no crisis. Our study is pretty much still work in progress. However, these are some of the possible strategies that can be considered to ensure continuity of cancer services during lockdown and beyond. Firstly, to improve screening coverage, maybe it's time that we adopt an online appointment system for cancer screening, or use community health workers to educate the community to use home-based screening kits. And then for those who are screened positive, the strategy is to ensure that they continue their journey in the system. Online delivery of test results, having a dedicated hotline which somebody is answering the phone line, or teleconsultation to manage these screen positive cases are some of the practical steps. To ensure access to cancer treatment, again, I must emphasize that a working hotline must be easily available for cancer patients to seek hospital appointments. At the community level, there should be volunteers or NGOs to assist and guide patients to reach the cancer center, something like what we have in the hospital, the patient navigation program. And then at the end of the continuum is the palliative care. There have been calls to decentralize palliative care to the primary care, as they are often the first contact to the community. So the GPs, the primary care, are in the ideal position to address the complex issues of health-related sufferings, because they already have the rapport established with patients and also the family members. So therefore, making palliative care accessible to the general population can ease burden of the tertiary healthcare system. This is the first time that a pandemic of a mega scale has affected the healthcare systems worldwide. So while the focus is still on the management of patients with COVID-19, we should also respond to the needs of other patients living with chronic diseases such as cancer. So our work on co-designing a contingency plan for maintaining access to cancer care is a collaborative work between the policymakers, public health physicians, clinicians, as well as members of the civil societies. If there is something that we need to learn from the pandemic, it is definitely the importance of a crisis preparedness plan to ensure continuity in the delivery of cancer care. With that, I thank you and wish all of you stay safe. We shall all emerge from this crisis, stronger and wiser than before. Back to you, Rini.
Thank you, Corinne. And I'm so inspired by your presentation. That is the essence of a healthcare system. It is supposed to learn, and we're not supposed to say the same and kind of wait for things to react to. I definitely do welcome any questions from our attendees for what has been presented so far. And last but not least, we have Dr. Diana Raj with us here today, who I think will outline for us the social aspect of living with cancer. And I think that, as Prof. Teo mentioned, it's neglected compared to kind of the health and the clinical side of cancer care. But it is actually something that is core and essential to the patient. So please do allow me to introduce Dr. Diana Raj, who is the co-founder of Cancerfly Networks and a public health specialist in training. Dr. Diana has 13 years of experience in the medical field, focusing on community health. And her most recent posting was as the district school health manager at Petaling District Health Office. Dr. Diana has been advocating for better quality of life for cancer patients and survivors since the inception of Cancerfly Networks, which she will tell us more about in her presentation. So I pass it over to you now, Dr. Diana.
Thank you very much, Ms. Winnie and Galen Centre for Health and Social Policy for this truly wonderful opportunity to participate in this roundtable discussion on strengthening cancer care. It's afternoon now already, so very good afternoon also to our distinguished panelists who has given us an interesting morning looking into cancer care policies and access to cancer care and support of course, to all the participants here who have come together with one important and common goal to provide improving cancer care for our patients. Is my slides visible?
I can see your slides with that.
Yes, okay. So just shortly, we have heard how we want to ensure that no person living with cancer is to be left behind. And to do so, data will have to play a huge role. I mean, we know data is needed to convince, to plan programs, to implement policies. But to our community, to our cancer patients, this would mean translating those data and research into a language that they would understand. And as we heard from our panelists, Dr. Faisal, we know that cancer care, it goes beyond just clinical management and involve other aspects as well. And so we at CancerFly, okay. So CancerFly in itself was a product of research or data coming to life. It was conducted by our founder, Dr. Sri Ganesh, whereby he found that employment was an important predictor of quality of life among breast cancer patients. So in CancerFly, our mission is to enable cancer survivors obtain a better quality of life through employment and business opportunities. So we know income is a critical indicator of the quality of life. We have seen even in the presentation by Dr. Teo earlier that about 85% of patients were impacted financially in her survey. And so we see that the patients actually go through this stage of from being healthy, diagnosed with cancer, going into treatment, and either it leads to death or recovery. But even in this recovery period, the increased burden in treatment, related costs, added with retrenchment and loss of employment, further affects their income and leads to a poor quality of life. As Dr. Murray mentioned, some of our cancer patients don't even have food on their table. And if they did have a job, did have employment, and CancerFly not only provides employment to the cancer patients, but as well as to their next of kin. So if this was able to be addressed, then you're definitely able to improve the quality of life of our patients. So this is just a picture of the late Uncle David. He's a cancer survivor who has been with us from the beginning, selling soft toys to obtain his financial for a living. So moving on, I'd like to share with you one of our highlights in 2019, which actually gave a glimpse of hope to our cancer survivors. So we did an online survey and we found that about 47% of cancer patients from the private sector workforce, they experienced loss of employment due to the diagnosis of cancer. And among these cancer survivors who experienced the loss, 20% were retrenched, 18% tendered volunteer resignation, and out of these, only about 4% actually went on to commence a new business adventure on their own. And about 2% were rejected by prospective employers and when they wanted to return back to work after recovery. So this program that we conducted was called Can Merdeka, actually reflecting that our cancer survivors can have freedom financially. So we started by actually sending out our proposals and obtaining, having discussions with the Human Resource Ministry as well as Jobs Malaysia. And we were truly very fortunate that Jobs Malaysia was very enthusiastic and supportive of the initiative. And previously they had special fairs for disabled patients. However, this was the first ever job fair program, especially for cancer patients. So this was broken down into 2 phases, whereby during the first phase, we had briefing sessions to engage with employers, basically to provide awareness on the effects of retrenchment and unemployment to our cancer patients. We also wanted to explore their perception and thoughts. And we found that similar to studies being conducted worldwide, there was this general stigmatization on cancer patients. Among the comments provided was that, if we hire them, they might not be as productive as non-cancer patients, and their notion that all cancers were the same. So, so what we did was to intervene briefly here to explain on the survival rates, explaining how each cancer had different 5-year survival rates, and giving them examples, like for example, a patient with thyroid cancer had a much higher survival rate compared to someone from liver cancer. So the the briefing and engagement progressed to the soft launch of Can Merdeka. Dr. Murali was present there, and we ultimately received an amazing number of 500 job vacancies for our survivors and their next of kin. And these were provided by various companies, including RHP, Jaya Groster, Secret Recipe, and many others. And on that day, there was health promotion. There was also a bazaar by our survivors who actually came forward to sell their products and gain an income. So this is actually the picture of our scoreboard. I didn't manage to get the updated one, but roughly this is how it looks like. And we can see we had about 14 employers providing 500 vacancies. And out of that, about 198 vacancies were filled on the spot for our cancer survivors and their next of kin. These are just some of the pictures of the soft launch, and we had the Adun from Dengkil, YB Adif Shan, who launched the program. These are some of the pictures of our cancer survivors selling their products, their handmade products, food, etc. So here in this picture, you can see that these are some of the survivors that came up to actually request for a job, and they were more on the younger generation. You see, younger survivors who actually have a longer duration of treatment for them and a longer lifespan. So having employment opportunity would really help them in this season. This is Jiran. Jiran is actually another child product of Cancerfly. When we say Jiran, in Malay, we know it means our neighbor, where we actually, it was inspired by our social cultural values within Malaysia, where we seek our neighbors' assistance when in need. And so from here, we actually want to provide caretaking for people who are unable to take care of their family who are admitted in hospitals. And so we have about 200 caregivers here registered with us. And these include nurses, physiotherapists, as well as ex-cancer survivors who would just want to basically accompany the patients in the hospital. So we actually started this in November, and in the areas of Putrajaya and Serdang. But subsequently, it was put on hold due to COVID, and caretakers are not allowed in the hospital at this moment. So another initiative worth sharing with all of you today is the proposal to have a double tax deduction as incentives for employers who actually afford employment to cancer survivors. So in that same survey that we conducted earlier, it showed that 91% of respondents who consist of Malaysian employers said they would consider offering employment opportunities if given a double tax deduction as an incentive. So we from Cancerfly actually brought this proposal up to the Ministry of Finance, and they were quite receptive of it, and they told us that they would get it into the 2020 budget proposal. But of course, due to political change and the pandemic, we were not able to obtain feedback on this matter. So basically, those were some of our recent initiatives. In all honesty, with the pandemic and movement control orders, it has brought about many setbacks and made engagement difficult for us, as well as to many others, I assume. So moving forward, we actually had handed in a proposal to conduct a nationwide survey to determine the prevalence of treatment interruptions. As we know, treatment delay can lead to disease progression and also subsequently to job retrenchment. However, there's been funding restrictions, and we've not been able to progress with that as well. So currently we are collaborating with CARE UPM, whereby they have a booth at the Hospital Pengajar UPM, and they would actually collaborate with us to provide us details on patients or next of kin who actually need a job, and we would convey that to Jobs Malaysia and try to obtain a job for these patients. So moving forward also, we would like to identify these patients experiencing financial difficulties beyond the Klang Valley, because this job fair was done in Klang Valley, and most of the jobs offered were within this area as well. So we would actually like to move on to different states, and of course having collaboration with centers that are offering cancer treatment would assist us in this. Besides that, we also have our CancerFly social media account where we actually promote our vacancies, and for those who have access to that, they contact us directly. Well, this is just a picture of the Golden Heart Awards given to CancerFly by the Star, where it's an award by the Star and Yayasan Gamuda celebrating NGOs who have commitment to social work. So that's just about some of our activities that we've been doing recently. And if we want to, our community, if we want our patients to actually experience the fullness of our research, the fullness of our data, then we need to translate it to a language that they can understand. And we at CancerFly try to do this. So I hope this presentation actually inspires us to translate data into more public health initiatives. Thank you.
Thank you, thank you, Dr. Diana, and all of our panelists. I think you have all highlighted a very, very important point that, data is actionable, but it needs to be oriented, it needs to be worked along with a community which uses the research, and also that because we don't have unlimited funding, and this needs to be somewhat of a focused effort. So I would like to just address a few questions to our panelists, and because they were just such excellent presentations. My first question is to Dr. Teo, if you are still on with us. It's great. I wanted to highlight, you mentioned that impact and evidence is part of strengthening the health system. And I just wanted to ask, from your perspective, how did you feel that establishing the Pink Ribbon Centers, which is in, I think it's in four hospitals, tertiary hospitals, and they're currently hybrid hospitals, I believe. How did that provide you information of where patient navigation should go, and how health and social care can be strengthened in a holistic manner?
Thank you for the question, Winnie. First off, I would say that the patient navigation program is not created by me per se. It was really, there are many different versions of patient navigation, and it was probably made famous by the ex-president of the American Cancer Society, Dr. Harold Freeman in the US. And what he did as one of the first African-American surgeons was to move from Memorial Sloan Kettering Hospital in one of the wealthiest part of New York to Harlem, one of the poorest parts of New York, and recognize that survival for breast cancer dropped dramatically because of the community. And it was not because of the availability of services, but whether patients could get to those services. So in Malaysia, the partnership program really started because of a collaboration between Cancer Research Malaysia and Dr. Yusof at PhAMA Hospital. And his frustration was really to recognize that 20 years as a surgeon, and you're still doing toilet mastectomies when you should really be talking about earlier stage of presentation and improving survival, was incredibly frustrating to him. So I think he recognized, together we were able to put together the funding, etc., and recognize that the biggest challenges were two things. One, how do you get patients in the system more systematically? What are the barriers from a patient perspective that enables them to come in? And then how do you get them to adhere to treatment? Because we already had a lot of research to show that adherence to treatment is what is actually going to improve survival. So I think what we started with was just a demonstration project to say that if you put navigators in place and coordinate the services for social welfare, coordinate services for survivor groups and so on, it's a navigation service. Are you able to improve the adherence to treatment? And we've been able to show that you are able to do that. So now the challenge is to go from one center to 4 centers to all 54 surgical hospitals in the country. And then hopefully to create a model that can go from breast cancer to apply to other diseases as well. We're not a breast cancer organization. We're really aiming to be able to find solutions that can translate to better care across the cancer spectrum for all patients. But we have to find opportunities by which this type of research can really translate to sustainable systems. So how we're going to move ahead would be that what we hope will happen is there will be a policy document which is already being developed that is about how patient navigation can be rolled out in a hospital setting. Beyond that, we'll be working out with the NGO partners, how do we sustain it at the local level so that the support groups as well as the do-gooders and the NGOs in a local setting can work with the hospital in the new navigation centers wherever they are in the country to be able to sustain local services for local patients. And that's something that we are aiming to build and really looking to see how some of the learnings that we have had from our demonstration projects can be developed into training modules that become scalable, that we can train and share and enable other people to do. Does that answer your question, Winnie?
Yes. Yes, it does. You mentioned that data comes from, it has to work hand in hand with outreach. So we don't just collect all kinds of data and then figure out what to do with it, but we actually have an intention and a deliberate attempt after we have managed to find, for example, that the pilot results were successful, therefore we're going to start to scale it up. And so my next question, and you mentioned sustainability, which is something that shouldn't be forgotten. I would like to ask Karine, after listening to your presentation, I was so inspired to hear of the strategies that you're proposing to come along with contingency and emergency preparedness planning. For me, it sounds like it would transform cancer care from what we have now. And for example, when you mentioned online appointments, perhaps to me, it is not something just for a crisis, but it's also now. For example, people who are in cities or they are not able to kind of go somewhere and to make an appointment, they can just use an app and just pull out their phone. So I guess this is kind of a hard question, I think, but what do we need to do, I guess, in the next year or maybe in the next 5 years to be prepared both for crisis, but also for the pre-existing crisis, which is the fact that people are already coming late and they don't trust screening, or and we do not know what they think. So from your research, perhaps you could share what do the collaborators in your research, for example, what do they need to move forward on contingency action planning?
Well, I think the pandemic has taught us many lessons, which is very informal. So what we are trying to do now is to learn from those lessons, and by using a consensus-based method of co-designing, we are trying to put forward a guideline which can be suited to different models of the pandemic. Yeah. So your questions on the online appointment, I think it is yes, it is a form of probably we're just taking it a step forward. But from what we see now, especially as we know, yesterday there is an official circular saying that the hospitals are to reduce the elective surgeries. So what is there for the cancer patients? What they need to do? Are they informed? As I know, a lot of them voluntarily did not turn up at the appointments. So is there any efforts taken from outside to reach out to them and to make sure that we keep them safe with us throughout the entire journey? So I think this is what we need to look at, not just from the health perspective, but also from the perspectives of the patients.
I agree with you, Karine. And basically, your research focuses on the hybrid hospitals, right? You mentioned that is dealing with the double burden of COVID and all of the other NCDs that, including cancer, which are very, very complex level of care. So I would like to move on to Dr. Diana. Actually, I would say that a lot of us here are healthcare professionals, including yourself, and we're not, at least I'm speaking for myself, I was not very familiar with social work or the medical social work department back in hospital. And I think that it is something that's overlooked, perhaps. It's not front and center of when we're doing treatment and care planning. And medical social workers also have limitations in terms of their human resource staffing, in terms of how many patients they need to serve within a huge hospital and many, many disciplines. So could you comment a little bit about how do you think Cancerfly, is there a plan for expanding? Is there a plan for working kind of more closely with existing health and social care workers? Because right now we're going to see worse implications with the current high numbers, and I think the retrenchment numbers, you mentioned 40% were either retrenched or they resigned. And so this is probably going to rise after, you know, this year.
Yes, thank you very much for the question. Yes, and true enough, I think we have to move forward from working in silo to really collaborating with the other agencies. For now, like we mentioned, we would like to actually move forward to other states, and we would like to collaborate with the pengaras of the cancer hospitals, at least if they can connect us. So whenever they have their clinics or whenever they have their road shows or any promotion, they can actually connect their patients who are in need of this to us, you see. So right now, because sometimes we just focus on the clinical management and we leave this part out. We fail to look into their finances and the difficulties that they're facing beyond their clinical management. So if we look at a patient as a whole and we treat them as a whole, then when we find that they actually need financial assistance, they can be connected to us. And of course, if we can formalize a collaboration within the health system, then that would be great. Yeah.
Thanks, Adina. I just think that you bring a really, really useful background from your work in Cancerfly into public health training, because you understand both sides of the story.
Yes.
And yeah, and so I would like to just ask, I guess, a final question to all of our panelists. We know that there are gaps in terms of certain kinds of data that we don't have, but we also know that there are gaps in terms of what we don't know we need. So from your perspective, from your professional field, what is perhaps a wish list, or that would actually enable you to deliver better interventions? And I know it's hard to pick just one, so feel free to just elaborate a little bit. Could I perhaps start with Prof. Teo? Would you like to elaborate a little bit?
So I suppose from a big picture perspective, what I would really love to have more of in Malaysia are behavioral scientists that can really try and understand how do we shift behavior in a scalable way among Malaysians, right? So for example, how do we shift behavior towards not thinking that cancer equals to death? So that, because the root of why people disengage with chemotherapy, for example, is because they believe that chemotherapy is worse than the cancer itself. Many patients believe that, and it's poisonous, etc., right? And those beliefs really alter how we make decisions about care, how we make decisions about going forward for screening, and how we make decisions about employing people as cancer patients in our workforce, and so on and so forth, right? So what I would really like to be able, if you ask me what is on the top of my wish list, would be really to have more people go into a field of behavioral science and to help us develop interventions that can really shift our thinking around what is cancer and how do we make better decisions around cancer care, cancer screening, cancer treatment, and so on. So that would be top on my wish list.
And before I go to our other panelists, I would also want to raise two of the kind of comments that were made in the chat box. And I think it's very important to raise at this point. Thank you, Mr. Teo Ai Hua, for raising the comment. Mr. Teo is actually a social, a very experienced social worker, and he is from the Malaysian Association of Social Work. His comment is that in many countries, social workers are specifically placed in oncology services, and they actually work hand in hand with the palliative care team to help with psychosocial needs. And Dr. Ednan has also very importantly raised that there's not enough destigmatization for palliative care. And this is not helpful for us because then patients tend to kind of just, maybe they either go all the way and they might give up on treatment as well. Yes, so there is data, there's evidence, but there's a need to use the evidence. So as what Prof. Teo mentioned just now, we know the attitudes of perhaps our family members, our relatives, when it comes to cancer. So that gives us actually signals as to what we should do next and how we can actually improve our system. And that's not going to come from the UK or the US. And yeah, maybe I could ask Karine next for your wish list of what you would like to see in your research, because you will be completing your public health training. So what do you hope to see coming out of this research? And yeah.
I think so far we have heard how the private sectors is willing to help the public sectors in terms of taking care of the non-COVID patients. So we should step into this opportunity to establish a partnership or a collaboration and look at how we can sustain these public-private partnerships in the long run for the benefit of our patients. We have to engage the end users to know what services is needed. So asking patients what they want is important. What we are doing now is we are acting on assumptions of what we know, but that is why we need needs assessment, and needs assessment is really, really important to make intervention to work as how we want them to be. So yes, I would like to emphasize that we need to include needs assessment prior to any policy making. Thank you.
Thank you, Karine. That's a very, very important point. And last but not least, I would like to just invite Dr. Diana to comment as well. CancerFly, I think, is going to play a very, very important role, and you're about to, I guess, also graduate as a public health specialist. So you're going to play a very important role in the whole health and social care system. What is your wish list for this year and moving forward? Dr. Diana, I can't hear you. Yeah.
Okay. Well, so we have come about putting such great initiative into obtaining these job opportunities. It's not an easy deal to go through this the task of obtaining, and as you saw our scoreboard, we had about 500 job opportunities, but although our small surveys show us that we have this number of people wanting the job, but they're not coming forward. So we need to actually find a way to actually get these people to come forward and fulfill the jobs provided.
I think we've temporarily lost Dr. Diana. Okay, well, just while waiting for Dr. Diana to log back in, Dr. Diana, are you back with us? We lost you temporarily.
Hi, can you hear me? I'm having a bad connection.
Yes, we can hear you now.
Yes. Okay, so, okay. Yeah, so as I was saying that we probably just need to bridge the gap between the supply and the demand. So we have actually gone a great feat to obtaining the, at least for Klang Valley per se, we've got the employment numbers, about 500 vacancies, but only about 200 were taken up. And that was because of the one-day approach. So we need to actually move forward to make this into a larger scale and actually obtain the, if possible, the true data, the true numbers of people needing this job opportunities, and if not, why, what's stopping them from coming forward if they actually want that job opportunity, and what's stopping them from coming forward, and how we can actually bridge the gap there. Yeah.
So thank you to all our panelists. I think you've covered a very diverse perspective on data, not only from implementation, but into research, and then into public health initiatives such as employment and social care, and also trying to integrate services that we know cancer patients and survivors need, but they're currently, we know they need it, but we have not actually, I guess, made movement towards integrating it into the service. Yes, so thank you so much. I'm truly honored to have been part of this panel, and I will pass it back to Ashrul now for the closing of the roundtable discussion.
Thank you, Winnie, and thank you for this, the remarkable presentations and discourse in that last panel, which is arguably one of the most important panels and issues moving forward, especially in the so-called post-COVID-19 era, and certainly in how we can do or build better. Ladies and gentlemen, once again, I want to thank you all for being able to attend this morning's roundtable discussion. I can't help but reflect and feel a little bit overwhelmed, honestly, you know, at the end of this session, you know, and it always happens to me, especially when organizing these sort of meetings, because there is such a diversity and richness of opinions and learned discourse, shared and lived experiences by everybody here on issues ranging from, we heard status and challenges of diagnosis, early screening, wanting to look at improving the care and treatment of people living with cancer, looking at issues surrounding palliative care and its marginalization and the need for us to talk about end-of-life services. You know, we've been hearing, and I think it's not enough, and we still have to do better to improve on increasing and providing the space, this, I think Ranjit called it just now, the survivorship space, the voices of people living with cancer, and also I think in terms of their caregivers and families. Also touched on was the issue of healthcare financing, which I think you know, could be central to some of the issues that we need to talk about. A lot of it really centers around how we look at the issue of funding for cancer care, but we also need to agree that it's not just about the money, it's also about how and where this funding is being channeled to. And to that, we look at issues linked back to funding. So linked back to the policies themselves that control how that funding is managed, and how well those policies have been able to respond. And here in, I think, Prof. Teo Su Huang's remarkable presentation that honestly, I never thought anybody could actually put together analysis of policies in one slide. And I think I saw it today, 3 reports, analysis, and 3 different, and 1 policy slide there. I mean, I'm going to have a look back again at that slide later on to see what I can actually extract from it further. But basically, we heard also embedded within the recommendations in that last panel just now about anchoring on firm policy recommendations on evidence and research data that we have been able to be fortunate enough to be able to obtain from the work that has been done by quite a few of our committed researchers in cancer. So, you know, there is a lot here that we can work with moving forward, and certainly, you know, people like to say that the night is darkest before the dawn, and I think, you know, it's one of those issues that we're seeing right now in the cancer space that we see around us when it comes to COVID-19. It seems to be overwhelming, dominating the healthcare space, and everybody's concerned about what's happening in the different parts of the world. And because of that, a lot of these issues are being left out. A lot of the non-COVID related issues are also being you know, marginalized to some extent because of the overriding priority. But, you know, there is a lot to learn how we're responding in the COVID-19 space and how we can apply that to the other areas of health. And it's important for us to not be overwhelmed. It's important for us to be able to keep that hope up and to be inspired by some of the people here. I'm already inspired listening to you all, the speakers here, and also the chairs in putting forward our best foot forward in terms of working towards building better cancer policies. So I just wanted to, before I end, to mention and give my thanks to all of the speakers. I need to do this roll call, it's very important. Of course, YB, Dr. Kelvin Yee, Dr. Rose Susanna, Dr. Murali, Dr. Faisal, Professor Aisha, Bun Lui over there in Kuching, Sarawak, Dr. Nur Nudiatul, Ranjit, Prof. Teo, soon to be Dr. Corinne, I'm sure, Teo Supeng over there, and Dr. Diana Raj, as well as my colleague Winnie Yong, for all of you for providing us with such interesting discourse this half day. So I just wanted to assure you that a report of the meeting will be prepared and will be made available for distribution in the weeks to come. A recording of this session is going to be uploaded onto our YouTube channel. We have online, and you should be able to get hold of that recording once we're able to, you know, clean up some of the audio bit and do some editing, and after that we'll put it up. So again, thank you all for attending and spending your time this morning. Stay safe, take care. And I just wanted to put out a PSA there on behalf of our Ministry of Health colleagues and every one of us. If you haven't had the chance to do it yet, please get registered for vaccinations so that you can be in line to get that vaccine shot and to be protected and to protect yourself and your family and your loved ones and your community from COVID-19. With that, thank you very much to all of you. We end this session. Assalamualaikum warahmatullahi wabarakatuh, and have a very good weekend ahead.